What if your blood vessels are silently failing and no one noticed in time? From deep vein thrombosis to pulmonary embolism, from varicose veins to diabetic foot, vascular conditions are widespread, dangerous, and often misunderstood. Pulmonary embolism can be fatal within hours. Diabetic foot complications lead to thousands of amputations every year, many of which could be prevented. Yet, in India, a country over 1.4 billion people, there are only around 600 trained vascular surgeons. It's a silent crisis, and it's time we started listening. In this special Independence Day episode of Rebooting the Brain, Dr. Sharan Srinivasan sits down with Dr. Vivekanand, one of India's leading vascular and endovascular surgeons and the president of the Vascular Society of India. He heads JIVAS, the Jain Institute of Vascular Sciences at Bhagwan Mahavir Jain Hospital in Bengaluru, an institution that has quietly become one of the country's most trusted centers for vascular care. Through this conversation, Dr. Vivekanand opens up about what vascular surgery truly is, what it treats, why it's often missed, and how the lack of awareness and specialists is costing lives and limbs. He speaks not only as a surgeon, but as a teacher, a builder, and a visionary, training the next generation in open and endovascular techniques, running one of India's first simulation-based vascular training labs, and leading a tight-knit, loyal team committed to academic and clinical excellence. This year, the theme for Vascular Day is Amputation-Free India, and it couldn't be more urgent. In a country where diabetic foot disease is rampant and limb loss is often accepted as fate, JIVAS stands as a symbol of what's possible: early diagnosis, limb salvage, multidisciplinary care, and hope. We also revisit the story of David Bloom, the American journalist who died from the pulmonary embolism while reporting from Iraq. His wife, Melanie Bloom, turned his legacy into a movement.
David was with the troops traveling in the legendary Bloom Mobile, but it was about tight quarters and remaining in one position for long periods of time. What do you remember about them?
Right, I spoke to him about 2 nights before he passed, and he was mentioning some leg cramps. But of course, he's in the midst of a war, and there was, so much going on, and we didn't make much of that. It was just sort of a passing comment. But only 2 days after mentioning the leg cramps, he was gone. And so I learned after the fact how very, very important those leg cramps actually were. It was a warning flag that both of us were fully unaware of. He had other risk factors, the long haul flights, the restricted mobility in the tank, and then dehydration from lack of water. But then to find out he also had a clotting disorder, that was sort of the perfect storm that brought about his death at age 39, young, fit, and healthy.
Proving how one story can awaken a nation to the dangers of undiagnosed vascular disease. As we mark India's independence, this episode is a reminder that health is freedom, and that freedom should include the right to walk, to move, and to live without amputations. This is Rebooting the Brain, and this episode is a call to action for a healthier, more aware, and truly amputation-free India.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവം ഉപാസ്മഹേ ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences. Namaste, everybody. Welcome to one more episode of our podcast, Rebooting the Brain. Today, we have another fantastic guest, Dr. Guest. But before I introduce him, I always start with my prayer. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityormam Amritam Gamaya Om Shanti Shanti Shanti. This has been one of the shlokas that's been my driving force since my childhood. As the shloka says, from ignorance to truth, from darkness to light, and from death to immortality. You can use these ideas anywhere in your life at any time and become a better human being, a better doctor, a better engineer, a better human being at the end of the day. So, hello everybody. I'm Dr. Sharan Srinivasan. I'm a functional neurosurgeon from Bengaluru, India. Today, we're going to talk about vascular surgery and its whole plethora of operations. But before that, some housekeeping rules. We have the Rebooting the Brain podcast. Please go to YouTube and subscribe to our channel. Please hit the like button. Please share all the videos that you like because more people can benefit. And definitely don't forget to click the bell icon. We also have a book called Rebooting the Brain, which is sold on the Amazon. You can pick it up. There's a lot of more information on the neuroscience that you can see. And of course, the Rebooting the Brain documentary. So now, let me now introduce you to my dear friend, our guest for the day, Dr. Vivekanand. Vivek, welcome to our show.
Thanks, Sharan.
My
It's wonderful to be here.
My pleasure. Dr. Vivekanand is a very senior vascular surgeon. He is the president current of the Vascular Society of India and the Vascular Society of Karnataka. He is the head of the Department of Vascular Surgery of JIVAS in the Bhagwan Mahavir Jain Hospital. Lot of things to talk about, Vivek, but first we talk about the video that you showed us just now about that journalist called David Bloom who was reporting in Iraq. Something happened to him, something called PE. Can you tell our viewers what is this PE, what is going on with this whole disease?
So what we're talking about is a condition called as deep vein thrombosis,
Okay.
and a complication of that is a pulmonary embolism.
Okay, got it.
Also called as a PE or VTE, venous thromboembolism.
Okay.
This is when a clot from the lower limbs,
Okay.
usually the calf region, that's where the clot forms.
Correct.
Because of various conditions. In his case, it was traveling in a APC, that's armored personal carrier, in a cramped condition for hours together in a desert, which
so he was
also
not
causes
moving the legs.
and also causes dehydration in these patients.
Correct.
Since they are in the desert. They've developed a clot, and once he gets out of the APC, stands up, that's when the muscle contracts, push the clot right up to the lungs, resulting in almost sometimes a fatal condition called as a pulmonary embolism.
I can imagine.
And it's that brought it to the notice of the general public. He died. Very, very unfortunate.
Very unfortunate.
Extremely young and tragic.
Correct.
But it also brought to the forefront to the world that pulmonary embolism is a fatal condition. And this is one of those conditions, both DVT and pulmonary embolism, one of the few conditions which can easily be prevented than treated.
Got it. So young guy, so it doesn't mean it can happen in any age. That's what you're trying to say.
It can happen in either age group, usually starting from the second decade onwards.
Got it.
So you need to remember blood keeps flowing.
Correct.
The moment there is slow flow states happening in the body because of various conditions, blood has a tendency to clot.
Like a water pache kartang. Correct.
Absolutely. So this is, again, if I could elaborate a little bit on deep vein thrombosis and pulmonary embolism, the leading cause of death, I would say the first or the second leading cause of death in the immediate post-operative period is actually pulmonary embolism.
Really?
It gets passed off as a heart attack.
Exactly.
But it's always
undiagnosed or missed
pulmonary embolism. And sudden death in the post-operative period is usually a pulmonary embolism until proven otherwise.
So you're making actually a very strong statement that, you have to prove it.
Yes.
So you are saying any surgery or only vascular surgery?
No. It's any surgery.
Any surgery.
Especially
so
orthopedic.
Why is that any surgery? Why is that specific in the sense because they're bedridden or what is
any surgery requires you to be anesthetized.
Correct.
And many surgeries, especially orthopedic surgeries, neurosurgeries, spine surgeries, where the patient is in a complete paralyzed state with sluggish blood flow in the lower limbs, have a tendency to form the clot during the surgery, and usually does not give rise to any kind of symptoms in the immediate period. Slowly the clot starts propagating, and once after the third day or the second day, when you make the patient sit up and start walking, is when the clot goes up. And you hear stories like,
Suddenly,
patient was perfectly fine, he was having a cup of coffee, and he tried to go to the bathroom. We were all talking to him, and then he just collapsed. And it's easy to blame it as a myocardial infarction or a heart attack, because that's what the patient would like to, patient's relatives would like to hear, because they understand it. If you tell them, like what you said, it's a lung attack, they wouldn't have heard about it. So they've all heard about a heart attack, but
it's crazy.
It is the leading cause of death.
So what Dr. Vivekanand just mentioned is lung attack. See, all of you are familiar with heart attack. Even stroke did not have the glamour or the urgency of a heart attack, and that's why we neurosurgeons and neurologists changed it to a brain attack. So now Dr. Vivekanand is talking about a third attack of the body, which is called a lung attack. He's going to talk about one more attack later on as we go through this conversation. So you are telling me that any patient, I agree with you completely about the risk post-op, because in neurosurgery we have sometimes long surgeries, more than 6 hours, 8 hours. So in fact, after anything we anticipate more than 6 hours, we are supposed to put the DVT stockings, because on table itself they can have a pulmonary, DVT that can form and things like that. So do you recommend that then we scan everybody before you mobilize them? Is that a recommendation of sort of a standard of care that you would recommend to cut down this risk, or what is the world recommending to, since it's the leading cause of death?
No, you usually start. There's no need to scan every person after the procedure is done. So, but you watch out for telltale signs in this patient. If you notice one of his leg is swollen in the post-operative period, think in terms of a DVT. Not necessary to do a scan. It's not technically feasible and not cost effective.
Got it.
But if you notice a grossly swollen limb after the procedure, or 2 or 3 days after the procedure, then start thinking that the patient could be having deep vein thrombosis. So the dictum is any surgery lasting more than 45 minutes has a tendency to form a clot.
45 minutes?
45. It takes 7 minutes for blood to clot.
You're actually redefining it even for me.
So
that's crazy.
So think they have a potential to form a blood clot.
It's better forearmed is forewarned as forearmed, as we say. So you're making a very powerful 45 minutes. That means doctors, surgeons who are listening to this podcast anywhere in the world, keep this in mind, because patient safety is paramount for us at the end of the day. Whatever we can prevent, we have to prevent. So that's a very powerful statement you made. 45 minutes. So we look at it and then we mobilize. Now, DVT, I've also heard, correct me if I'm wrong, it can be in the leg, calf, or even in the pelvic veins. Which is, is there really this thing of pelvic veins being as much as risk can be missed because the Doppler sometimes ends at the thing?
Yeah, that's a very pertinent question that you raised. So basically, DVT occurs in any of the deep veins of the body. So you have superficial veins which are right next to the skin. Looks ugly, but they're not life-threatening. Deep veins,
like a varicose veins, which we'll come to later. We'll come to that later.
So deep vein thrombosis is usually underneath the fascia. So all the veins in the abdomen, all the veins in the neck, and upper limb, and the lower limb. So any of these areas are potential for forming a deep vein thrombosis. Majority of them come from the calf vein sinuses. That is where that the calf muscle is also called as a peripheral heart.
Correct.
It stores around 200 to 250 cc of blood, especially when a person is flaccidly lying around during surgery, especially with spinal anesthesia or subdural anesthesia, where there is complete paralysis of the limb. Blood accumulates there, and if all the conditions are right, it starts clotting. The other area, especially in females, post-pregnancy. Post-pregnancy, you must also remember that, the second most leading cause of death in a post-pregnant puerperial stage is again deep vein thrombosis with pulmonary embolism.
Oh, I didn't know this also.
Yes.
Oh,
So
why is that?
why is that?
Oh, they are
Okay.
having some prothrombotic.
Yeah, it has a prothrombotic condition
That I
because
know.
of to maintain a fetus, you need high levels of progesterone. The body naturally produces it. So it improves the placental circulation, but it also dilates all the veins in the calf region, as well as the whole pelvic vasculature is sort of designed to give extra blood supply to the uterus as well as take it away.
Correct.
So you have huge number of veins in the pelvis. Usually this after the pregnancy is over or a period of 6 weeks tends to involute.
Okay.
In this 6 weeks, especially if they're dehydrated or if they have other conditions, that's when clots form in the pelvis. Can it also give rise to a pulmonary embolism? Yes. And when we do a scan, we usually look at the lower limbs and then we say no DVT.
Exactly.
Yes.
So you have to ask higher up also.
Higher up scan going right into the abdomen. So now part of a venous Doppler goes right up to the IVC, and if they see prominent veins in the pelvis, it causes. With increased use of central venous catheters, we've started seeing more of
which I have seen, the upper limb, and yes, I've
upper
seen
limb
that,
subclavian vein as well as
correct,
the internal jugular vein
correct,
can also cause deep vein thrombosis, malignancy,
correct,
PICC lines,
correct,
chemoports. All these things are increasing in number.
Amazing. So it's so just to summarize, you're telling me that the venous Doppler, everybody is doing it till the IVC,
No,
or
now it's part of the recommendation
So
that all the people.
so if I
all
just said
across-
venous Doppler lower limbs, I'm assuming they'll do it till the IVC.
Till the IVC.
They should do that.
But invariably what happens is now if the patient's habitus is very big, he's got a big tummy, if there's a lot of gas in the bowel, you may not be able to visualize the iliac veins. But if the iliac veins have a clot in it, invariably the thigh is swollen. So you can't have an isolated iliac vein clot.
Okay.
So it's clot going all the way to the top. So usually they'll have clinical signs when you examine the patient carefully.
I had a senior of ours when we were in Bangalore Medical College, and he was senior to us. He was a general surgeon, got married. He was traveling to Tirupati post-wedding. Coming back, old Fiat car, no seat belt, no concept. He had a head-on collision. He had a classical, dashboard injury. He had a fracture dislocation of the pelvis, of the hip joint. He was on traction. He was initially in Manipal. Then they shifted him to, Chinmaya because father worked there. 6 weeks later, he suddenly had a PE and died in the hospital. So classically, this is
even simple fractures, foot fractures, which are treated with a POP cast. Okay, so when they put a POP cast, goes across the ankle, comes right till the middle of the calf.
Correct.
So it prevents active movement of the foot.
Correct.
Both plantar flexion and dorsiflexion is prevented. So the calf vein starts getting activated because your gastrocnemius and soleus muscles are not contracting. They have a tendency. So if the patient starts complaining of pain in the calf region, please don't dismiss it.
On the cast.
Got it. Don't dismiss it as a muscular pain and just treat it with anti-inflammatory.
Got it.
Need not necessarily be a deep vein thrombosis, but keep in mind.
I agree. And you can't even scan it until you remove the
cast. So high index of suspicion is needed. So that is why that saying which says a stitch in time saves 9.
I agree.
I think any disease, if you catch it early, can be easily treated.
Absolutely. Prevention first.
And better prevented.
Yes, I agree with you. In fact, I tell the family of a patient who's paralyzed once, keep moving the foot 1,000 times an hour. And I say 1,000, at least they'll do 100 times because the calf muscle needs to keep pumping at the end of the day. So that's quite scary. And in fact, in flight, they say if you're traveling long time on a flight, you get up and keep moving the feet, walk up and down so that you're the P. A lot of people on flights have got PE.
Yeah,
this funda
it's called as a economy class syndrome.
I didn't know this.
Yeah.
Really?
So long distance flights which go transatlantic 12 hours, 14 hours.
And tight seats.
Yeah, tight seats. Many patients don't hydrate themselves because they have to keep visiting the loo. So they get dehydrated. Plus it's a pressurized container.
Correct.
So that itself causes stasis.
Really?
Yeah. So
there's
many
an additional
people,
risk because of a pressurized cabin?
Yeah.
Oh, I didn't know this.
So all these factors combined together in one unfortunate individual Who that person is, nobody knows. So you
The
always
masala
tell
for
them. Yeah.
disaster.
So you always tell most
Oh,
of these
shit.
patients, especially those who have varicose veins,
My goodness.
slightly overweight, or who have a previous history of deep vein thrombosis, keep moving your ankle up and down. We tell them to move up and down the aisle. Sometimes it's not possible,
Correct.
but at least
least
go
keep
cross-legged
Pumping.
and keep pumping
Pumping.
your calf muscle, just moving your ankle up and down.
So moving this up and down like this is very important, guys, to get your things going.
I'll give you a very interesting anecdote. There was a survey done in the 1970s when duplex ultrasound started becoming more popular in the US, and it was actually reported in Journal of American Clinical Psychology. So they started interviewing teachers.
Okay.
About 400 and odd lady teachers who had pain in the calf region towards the end of the day and discomfort. They started noticing that, these people early in the morning are very lively, very active, and love their profession, teach well. Towards the afternoon and towards the evening, they start becoming more restless and they start getting more angry and irritable with the students.
So, assuming the DVT has happened, and then how do you minimize the risk? Now you know that he's got a DVT, whatever it is. So, how long the risk of PE happen? What do you guys do? How do you minimize the risk? What should the family look for? Because I'm assuming that many of them are treated at home. How do you admit everybody?
Previously, when we started our career around 25 years back, any case of deep vein thrombosis used to be admitted.
Okay.
But now for the past around 10 years, it's only if the deep vein thrombosis is proximal to the femoral vein, that is proximal to the hip joint, we tend to admit them. Any deep vein thrombosis in the thigh or in the calf region, we treat them with injections with proper counseling. With proper counseling. So usually deep vein thrombosis has to be managed medically. Very minimal role for any kind of intervention in these people. And anticoagulants or blood thinners, powerful blood thinners are needed. First is to prevent the clot from propagating. And then going into the lungs. The risk of deep vein thrombosis is it should not move to the lungs. So usually people or patients are very concerned about a swollen limb and pain in the limb. Usually starts coming down at the end of 1 or 2 weeks.
It takes so long.
Swelling will slowly start coming down. For the swelling to really come down takes anywhere between 6 weeks to 3 months. So our treatment parameters are not towards reducing the limb swelling or the pain.
Neither is it important. As a parameter.
Our goal in the first 2 weeks is when the risk of pulmonary embolism is at its highest.
2 weeks is where the highest risk is.
So this time of the treatment is dedicated only towards preventing a pulmonary embolism and prevent further propagation of the clot. Body usually does most of the clot dissolution. So you're giving medicines to prevent it from
propagating. So the medicines for propagating.
Yeah. So anticoagulants are given to prevent propagation. And like I told you, many of the duration of treatment can go on for 3 months, sometimes goes on up to 6 months. Some vulnerable patients who have underlying condition, they go on lifelong with anticoagulation.
So you obviously ask them to come back periodically and see and all that. Do you encourage people to do massage for the pain and all those things when the DVT is there? Or is there any do's and don'ts so that you can tell our audience that?
Very, very important for the patient to be told not to massage his calf muscles or his thigh muscles, because they're so concerned about the pain and concerned about the swelling that you have. So you have a lot of people coming up with advices saying that use this. So the sudden muscular contraction taking place anywhere in the body, especially the lower limbs, gives rise to this condition called as pulmonary embolism. So in addition to avoiding massages, patient can walk. He can go to the toilet. Avoid sudden muscular contractures. We ask them not to squat. And the other thing is preferable, if possible, try not to use an Indian toilet at least for the first 2 weeks. But many a times, in our settings, it becomes very difficult.
The commode chair is
that is available. That's what we tell them.
Correct.
Because it's very important for us to tell them, because in the
Correct.
hospital treatment is different.
I agree.
But when they go home, so we need to tell them about.
They don't realize the impact. See, people have lots of things. They don't take it seriously.
I have a sad story to tell about a young 18-year-old girl who was studying in an engineering college.
Okay.
First year, she had come all the way down from Delhi. She came to the clinic, to a hospital with her friends, parents not here. Leg pain, leg swelling, not just the leg, including the thigh. She was in discomfort, she was in pain. So I said, when did this start? She says, I had to take some hormonal pills to stop my periods because there was a puja.
Oh, wow.
And this is one of the conditions which causes a deep vein thrombosis, one of the risk factors. Happens once in a while. And we got a scan done. The clot was almost till the near level of umbilicus. That is the common iliac vein.
And just for 3 days?
3 days.
Of the tablets. Crazy.
3 days after that. And then we told her as well as the friends, all young kids, teenage kids, first year of engineering. No, it's a serious condition, needs admission. And they were not ready for admission. They said, no, we don't want to get admitted. I said, let me talk to the warden. Spoke to the warden. They said, no, we can't take a decision. The parents have to take a decision. So it was, I insisted on speaking to one of them or any family member who's a doctor. So I ended up speaking to the father itself, educated person, well-meaning person. So I told him, it's very important for us to admit her and treat her. So he said, Doc, mother is saying no. I'll be coming tomorrow morning and then we will meet you. Unfortunately, in the middle of the night, I get a call at around 2 a.m. saying that, a young girl has been rushed into the casualty emergency section and she is not breathing.
Gone.
I felt so miserable.
I
thought, I should have
caught them by the collar and put them inside.
I should have done that. I spoke to them, but maybe my convincing skills were not good enough because there is a degree of suspicion both among the patient as well as among the parents saying that, all doctors want to admit patients, everybody wants to do. And if you tell them that, she thinks maybe it could be a sprain because of her gymming.
Correct.
Somebody comes with a leg pain, calf pain, and you tell them you need admission and emergency you may potentially lose your life. They think, we are fibbing.
Overkilling.
Sometimes,
that's why
even to this day, I regret that.
I can see it on your face.
Yeah, it's once life lost and easily it could have been treated.
Exactly.
I gave her the first aid and sent her, but maybe
take some time. I know.
I wish I could have prevented that.
I can imagine. Same story. I spoke to Dr. Anil Neurology about the period postponing pill causing brain stroke, CVT, and venous infarct. So the logic is the same. The location is different. And this period postponing pill is a double-edged sword, even including OCT, if they take it for this.
No, you'll be surprised to know that, youngsters popping the morning after pill.
Very frequent, no?
Extremely frequent. And they come to the clinic or to the outpatients with a swollen limb. And absolutely young person who's in 18s and 20s.
And then you think about this.
No, we don't think about it. It's very difficult for us. So we get a scan done, we ask, and then we ask them,
you probe.
The two common conditions, what we really ask them is, what really caused it. Usually smoking is what we ask. If the parents are there, they're not going to say anything. And for a lady to be telling that, she popped a pill in front of the parents or attendants is very difficult. So we asked them, did you take any hormonal manipulation to postpone the period? Some of them open up and say that, so that we get a clue that, it could be the reason. And the other thing we've noticed in, early pregnancy, we are seeing a lot more deep vein thrombosis, which was not there around 10, 15 years ago.
Why?
Then we started
with
the IVF rate going up.
Correct.
Okay, all of them are having
hormonal treatment,
hormonal manipulations, and makes them more susceptible for developing deep vein thrombosis. So we need to tell the doctor too that, you're undergoing treatment, your patient is undergoing treatment for IVF, watch out for the legs.
Crazy.
So because of the hormonal manipulation, there will be some leg swelling. Don't ignore it.
Crazy.
It's,
Thinking just DVT, just vein, how much is going on? Yeah, I didn't even know all of this. So, guys, period postponing pills, you want to have fun, you can do that. But reality is, please remember, not at the cost of your life. And those women or the couples who are taking IVF treatment, be forewarned that you don't have to be worried, you don't have to be paranoid about it, but keep it at the back of your mind that any leg swelling, please do not neglect. Go to a vascular surgeon. Don't go to somebody else who doesn't understand DVT.
Or even they can go back to their obstetrician.
Okay,
but just bring it to
yes, at least
medical
specifically.
specialist.
Make sure that you have chased it down to ensure that this has happened. Do not neglect, and please understand, lung attack can be fatal, and before you know what's happening, you're all done and dusted. You become a statistic. So we started with the vascular system has two parts, veins and arteries, and we started with one part of the vein called the DVT because of the video that you started. So before I go deeper into varicose veins and everything else, what is vascular surgery? Can you explain to our audience, because it's such a misnomer, because as my board says, nerves are not equal to blood vessels. There are a lot of patients with so-called varicose veins saying nara problem coming to a neurosurgeon, and I say it's not my problem, go to vascular surgeon. They're upset with me. Yeah, doctor, our nara problem. So in our local colloquial language, nara means nerve, and they don't understand it's a blood vessel. So I think you have to break this misnomer and tell people what is vascular surgery.
So vascular surgery, like neurosurgery, you have the nerves traversing starting from the scalp right down to the toe.
Correct.
Similar, the blood vessels travel every part of the body. For it to maintain its vitality or to survive, needs blood supply.
Got it.
So vascular surgery is that branch of surgery which deals with all the blood vessels, both the arteries and the veins, all across the body. But we stop short of the blood vessels inside the brain, and we stop short of blood vessels in the heart. That's dealt by a cardiologist, and blood vessels inside the brain are dealt by the neurosurgeons.
Correct.
And rest of all the blood vessels, and remember, it's not just the arteries, it's also the veins.
Exactly. So it's a huge thing
it's
for
you. It's a huge field. We are as general as general surgeons can be.
But yet it's a super specialization, and it's such a challenge. I see, because guys, we share the same theater, so I see how busy these guys are, what all they're doing. It's it's quite fascinating, at the same time quite frightening to understand that I can be the next statistic. Because vascular surgery is also, vascular disease also very democratic. It affects anybody. It's not young, old, male, female, rich, poor. It doesn't matter. Anybody at any time can be a victim to this whole process. I remember you telling me when you were chatting, your dad didn't understand what vascular surgery was.
Yeah,
so what was that part of the story?
It's like this, So my dad is no more. He was a professor in Agriculture Sciences College. Not that, he was an uneducated person. And so when I told him that, I'm interested in vascular surgery, so he was overjoyed. He thought it's cardiac surgery.
Oh, okay.
Cardiovascular surgery.
Okay, got it.
So then I said, no, I'm not interested in the heart. I want the other blood vessels. It's a separate specialization. So he said, other than the heart, so you're scared to become a cardiac surgeon? No, I said, I'm not scared to be a cardiac surgeon. I just want to be a vascular surgeon. There are enough cardiac surgeons around. I want to be a vascular surgeon. Even after me being almost around 10 years in the profession, he always felt that, I should have become cardiothoracic and vascular surgeon. And then finally I told him, the NMC has completely separated cardiothoracic surgery from vascular surgery. And then, he reluctantly agreed, saying that, okay, you take care of the limbs. I said, no, we just don't do gangrenes. We do a lot of other stuff. So it was very, very difficult to convince him. And we find that problem even among doctors in the cities, as well as in the peripherals.
Amazing.
So we conduct talks all in medical colleges and in smaller places. To break the myths
of vascular surgery.
Yeah, to tell them, what is vascular surgery, what all we do. So it's commonly assumed that, we do only varicose veins, or we just take care of gangrene.
Got
So
it.
we tell them that, every part of the
Yeah, I
blood
mean,
vessel.
I see the kind of work that you guys are doing. It's amazing high-end work that you guys are doing. And we will talk about all of that for sure.
So, like I told you, we deal with all the arteries and veins all over the body.
Got it.
And what is so special about our field is we do not have a medical counterpart. So we are only vascular surgeons, plus we are vascular physicians. There is no course called as
Like a
vascular physician,
neurophysician, neurosurgeon, or a
urologist,
nephrologist, neurologist.
urologist, cardiologist and
Very
cardiac
true.
surgeon,
You're
medicine
right.
and surgeon. And
Correct.
ours is the only field, only
Why?
super specialty, which
Correct.
has both medicine and surgery being given equal importance in our curriculum. And we are both physicians, and we wish, we get the help of vascular physicians. I'm sure,
Interesting,
the
no? It's very
council
interesting.
will
True.
listen
At some
and
point,
then
yeah.
form syllabus for angiology.
So you are like a schizophrenic right now, writing
Absolutely.
both. Yeah, clearly.
Absolutely.
Yeah, see, as a surgeon, always our hands are full dealing with all those problems, because it's not just about surgery. You have the perioperative stuff going on. On top of that, you have to break your head on all of those things. I know, your department is doing phenomenal work. We're going to come down that path sometime, but it's crazy. Oh, so vascular surgery, guys, is for all those MBBS doctors who are listening to this podcast. I think seeing the kind of work that Vivek and his team does, I think if you are thinking of a surgical specialty, I think this is one of the things you must consider very, very actively. It has no, what is that, recession. It has no expiry date as far as because there was a MBBS doctor who asked me once in AIMS about 10 years ago, sir, is there a future for cardiac surgery? Literally asked me that question. And I said, first of all, I'm a neurosurgeon. I'm not the competent guy to ask, but he was very concerned. He was interested, but he was feeling that, more and more endovascular stuff is going on. I said, the only way you can do it is you become endovascular cardiothoracic surgeon, rather than like how neurosurgeons also getting into endovascular surgery. So let's go back to the veins. We'll go back to join the arteries a little later. So the next big problem is varicose veins. So can you tell our audience what is this varicose veins, and what's this whole story all about, and what they should do about it?
Okay, varicose veins. Before going into the specifics of a varicose vein, I just like to tell everybody that veins are needed in the body to take the deoxygenated blood back.
Correct.
So the heart is a fantastic pump. It pushes blood right down from the chest right to the toe.
Correct.
And it's got fantastic 4 chambers with very, very strong contractile muscles.
Correct.
It pushes 100 ml of blood back. And before it can contract again, 100 ml of blood has to come back to the heart.
Back to the heart. Correct.
And there is nothing pushing it back to the heart. Heart can push it down, but it can't pull it up.
Correct.
So you must remember, you have the veins in all parts of the body which are silently pushing blood back, and nobody talks about the veins at all. So they are much, much more efficient.
Warriors.
Yeah, they are much more efficient than the heart in taking blood back. So your heart can push out 100 only if it gets 100.
Correct.
If you don't get 100, where will you push out? You'll only push out 60.
Or whatever.
Yeah, whatever comes into it. So it's like, you see a row of ants carrying stuff way beyond their weight.
Correct.
And then working in synchrony.
Correct.
That's what the veins do. So veins outnumber the arteries almost 4 to 5:1, taking blood back into the system.
I see.
So instead of using the term varicose veins, we usually use what is called as chronic venous insufficiency.
I see.
Okay, varicose vein is one component of...
okay.
So we call it as chronic venous insufficiency. So what happens is that the vein starts weakening for whatever reason. And the return flow of blood is not as good as it's getting, the limb is getting.
Especially when they're against gravity.
Yeah, against gravity. So you're sitting down most of the time.
Correct.
Or you're standing for a long duration of time. Blood has to be pumped against gravity, and for whatever reason, we'll come to the reasons later, the return flow is not that good. So initial stages of chronic venous insufficiency, you have people who complain of calf pain, calf heaviness, and tired feeling in the calf region towards the end of the day. Middle of the night, they start getting up with cramps.
Oh, that
So
can be.
these are all
Really?
early signs of
I have so many patients come to me with nocturnal cramps, and I think
yeah,
it's.
and we all think in terms of magnesium deficiency and that deficiency. So we did a
You did a study on that?
we didn't do a study, so
Huh.
we just I met a lot of teachers working in a school in Bangalore South, trying to figure out how many of the teachers have this kind of problem.
Okay.
So usually it's said that professions which involve standing, like nurses, teachers, policemen, doctors, have this calf tiredness. So what's happening is these people start developing heaviness in the calf region, tired feeling, worsens before periods, and this is there for such a long time that the ladies start accepting that it's part and parcel of their life. They think they all blame it on hormones.
It's more. I
yeah,
see it more common in women than in men.
and women, little more commoner in women than men.
Correct.
So that's how it first starts off, and then
something new today.
over a period of time they might start getting swelling of the legs towards the end of the day, and also you might start seeing little prominent veins.
Correct. I was just going to tell that a lot of women come and say this mild prominent vein.
Yeah.
I say a lot of people have it.
A lot of people have it. And later you start seeing pigmentation around the ankle. It's called as the gaiter area. That's at the later stages of chronic venous insufficiency. When you see a grossly dilated vein which is abnormal, that is when it's called as a varicose vein. So that is a small part of chronic venous insufficiency.
I can understand right now. So let me ask you a question. Sorry for butting in. From that so-called calf tiredness, end of the day, till the time this florid varicose veins come, what's sort of the time that can happen?
Venous insufficiency is a very, very slowly growing. It literally is like how the termites eat up into a wooden wall or a tree. It's a very, very slow process which goes over decades. Many of the ladies who get varicose veins, visibly grossly dilated veins, usually the seeds of it, if it's not congenital, that means hereditary, 30% is hereditary. They develop it after the pregnancy, could be the first one or the second one, because of the hormonal changes which take place during pregnancy.
So they never reach baseline again.
Yeah. So then what happens is it doesn't manifest itself then. It manifests itself 8 to 10 years after pregnancy with all these symptoms with 1 or 2 veins. And we all tend to dismiss it saying that, it's just 1 or 2 veins. Don't worry, nothing will happen about it. Then over a period of time, the veins start getting bigger. Somewhere around 40s, 45s, the second insult to the woman's hormonal homeostasis happens.
The menopause.
Perimenopausal age group. So 5 years before menopause and 5 years after menopause. Menopause is one particular date or one particular year.
Correct.
So 5 years before it and 5 years after it, it goes through a tremendous amount of hormonal imbalance. It starts worsening. So many ladies who present in 60 years or 65 years, if you ask them how long it's been there, or they say only for the past 4 or 5 years. That is when the deterioration starts. But the seeds of it are usually planted during pregnancy and childbirth.
I mean, this is an incredible message you're given, even for somebody like me to understand. I'm honest about it. I didn't know this. So now, to take this deeper, are you telling somebody like me, because a lot of patients do come to me, they come to me with something else and they just happen to mention I have this calf muscle pain at night, nocturnal cramps, and I say the same what I was telling you. Are you suggesting me that I should make them to see you, get a Doppler? What do you think is, how do you catch this early, in the sense that should I suspect everything? Is it worth doing it? Like how everybody gets an ECG done, everybody gets a cholesterol done. What is the way? It's like a vaccination program. Do you have
any physician or any vascular surgeon or any surgeon who spends a little time trying to understand the patient's symptoms will be able to get a clue as to what is happening over there. So if you talk to the patient and then you realize that, they are giving you the classical symptoms of chronic venous insufficiency, can be treated easily. It might need stockings, lifestyle modification, exercises, little bit of medicines. So many of the people seem to think that, if they develop varicose veins, they need to undergo surgery. No, surgery is the last part
only
of venous
the
insufficiency.
Big fellows who come in.
Yeah, the big fellows who come in with grossly dilated veins or bleeding. Less than 10% of people who've got venous insufficiency really need surgery. But rest can be managed with lifestyle modification and stockings.
Amazing. In fact, I remember a couple of cardiac surgeon friends of mine used to wear stockings because the same vein is taken for harvesting during bypass surgery. They said, I wear it because we stand and operate and things like that, just as a side thing. So, viewers, what Dr. Vivek is trying to say very clearly is it's a slow, indolent process, doesn't create too much of a problem. It's for you to really seek help as an urgency, because of which you tend to push it under the carpet. You give different reasons for not making it happen. But remember that a stitch in time is, again, it's coming here. The same story is trying to say again and again that you catch it early, take precautions, then you can even avoid it from becoming worse, and for sure not worry about surgery. And even if you do get varicose veins, only 10% need surgery if caught early enough. I think that's a fantastic message you have given, to the audience.
No, we can relieve them of their symptoms. They don't have to suffer.
Correct.
They don't have to suffer for
ತುಂಬಾ ಭಯ for a varicose vein surgery. They get scared.
No,
sir, doctor hತ್ರ surgery ಮಾಡ್ತಾರೆ and they're in that whole process.
No, it needs some form of therapy.
Correct.
So when the calf muscle starts paining, or if they start noticing swelling towards the end of the day, your body is telling you that something is going wrong. Please help me.
Correct.
Okay. All it needs is few exercises and stockings. It just needs it. It does not mean surgery at all.
Amazing.
Hardly surgery is recommended for people with venous insufficiency. I'll give you a very interesting anecdote. There was a survey done in the 1970s when duplex ultrasound started becoming more popular in the US, and it was actually reported in Journal of American Clinical Psychology. So they started interviewing teachers.
Okay.
About 400 and odd lady teachers who had pain in the calf region towards the end of the day and discomfort. They started noticing that, these people early in the morning are very lively, very active, and love their profession, teach well. Towards the afternoon and towards the evening, they start becoming more restless, and they start getting more angry and irritable with the students. So they started noticing a pattern.
Okay.
And they didn't stop at that. Then they went and started interacting with the family members. And the family members also said that, towards the evening, she's snapping at the children, she's snapping at the husband. She's very, very irritable.
Okay.
Then they started going into the depth with the teachers. They started asking what happens. They say from 2:30 in the afternoon, the calf pain is so dragging. It's this dull, aching pain towards the end of the day, which is not severe pain, but it really saps you of your energy. Yeah. Towards the end of the day, they're all irritable, or, they just want to lie down. They don't want to do anything. So then they started, they got a scan done for them because it was part of a bigger study. And they got a scan done towards them and found out that most of them had venous insufficiency, not varicose veins.
Got it.
They had venous insufficiency, and almost 70% of them, their moods changed by wearing stockings.
Amazing.
Just return circulation.
Amazing.
Started
imagine
having
something solution here, and the mood is.
Absolutely. It's this chronic pain in ladies which drives them nuts at times, not just in ladies, anybody.
I agree.
And ladies tend to tolerate it for a much longer time because they're sort of conditioned, saying that no, this is pretty normal. It's not normal. If there is pain in any part of the body, your body is telling something is going wrong. Okay, pay attention, and you can easily get better.
Amazing. If stocking has solved the problem, can you imagine? Amazing. Yeah, that I think is incredible what you said. And I'm quite sure all your women and men and whoever is listening to this, you're having this sudden change that you're seeing yourself or people around you. It may be as simple thing as this. So please be aware of it. And then again, stitch in time saves 9, as what he says. Please go ahead and get the right things done, and it makes a difference. So how important is medical management for a peripheral arterial disease, as what we call? So is it different for different areas that you described, or is it common?
So atherosclerosis is the same in whichever part of the body.
Correct.
So medical management forms the bedrock of treatment of any form of treatment. So you always start the patient on medical management. So in his case, most important is lifestyle modification. Smoking cessation, if it's there, is the most important component. Otherwise, any form of treatment without stopping smoking is not going to give durable results. Good lipid profile control, as well as diabetic
Cholesterol and all
management.
those triglycerides.
Cholesterol, triglycerides, and good diabetic management.
Hmm.
And then we go on to dietary modifications. Then we go on to the medicines. So basically the medicines what we usually use are blood thinners. It could be in form of antiplatelet agents, or it could be in form of anticoagulants at a lesser dose. Then we add statins to reduce or modify the lipid profile.
Correct.
Statins, very, very important for us because it not only stabilizes the plaque, it reduces the plaque size also.
Oh, I see.
Over a prolonged period of time, especially documented in the carotid artery, including the intermedial thickness starts coming down with appropriate usage of statins.
One thing we forgot in PE before I come back here, it was IVC filter. We forgot to mention that. So there's a special procedure that people like Dr. Vivek and his team do when the DVT is very high. I just missed that, so I just brought it up. Can you tell us a few minutes on what is this IVC filter and which kind of patients of DVT do we use it?
So if a patient has proximal DVT, that is, deep vein thrombosis in the thigh or in the abdomen, so the risk of pulmonary embolism increases in them.
Correct.
So these people, the bedrock of treatment for deep vein thrombosis is blood thinners, anticoagulant blood thinners, like heparin, low molecular weight heparins. So there are many conditions in which this drug can't be given. If the patient has undergone a neurosurgery 2 days back, if I give him a blood thinner, he's going to bleed in the brain. If he's got a polytrauma, and if I give him, he's going to start bleeding from another part. Or if he's undergoing a major surgery, or if he's got a gastric ulcer which is bleeding, I can't give him a blood thinner. So I'm constrained. So to prevent a pulmonary embolism from happening, you insert a device called as IVC filter, which is a mechanical obstruction. It's a porous filter for blood to go. Blood return.
It's like
literally like a filter.
Whatever.
Yes, absolutely. And then it's placed in the inferior vena cava, and it's a percutaneous procedure. You do not have a cut anywhere in the body. Either you go from the jugular vein or you come from the femoral vein. It's just like a puncture in the vein, and then we introduce the device.
And you do it in the cath lab, or
you do it in a cath lab or in a place where there is C-arm facilities. And then once it's placed, the risk of a fatal pulmonary embolism is more or less completely eliminated. So then the rest of the treatment from other parts, even without anticoagulation, can go on. And later, once the anticoagulation is started, if the patient is good enough for it, you can also go ahead and take the filter out and let the anticoagulation, the drugs do their job.
So people like Dr. Vivek and team have done this for a lot of our patients, because in neurosurgery, we have this constant risk where we have the risk, but we cannot give the medicines. And all of them have done well. Thank you for taking care of our patients. I think it's very important.
That's what we're there for.
I agree. That's where the multidisciplinary teamwork is very critical, so that the patients get the best out of the whole process without, losing time. So coming back to varicose veins. So those who actually, let us say those 10% who need surgery, if at all. So so can you tell them you don't have to be scared about it, what kind of surgery it is, how easy it is, and how, whatever, cosmetic, they think they'll cut open everything. People have all sorts of, things going on in their minds.
So when we come to surgery for varicose veins, so usually varicose veins is one of the component of venous insufficiency when you have a visibly dilated and a tortuous vein in the leg or in the thigh.
Some of them burst and start bleeding also, no?
Yeah, occasionally. Those are the complications of varicose veins, when you can have bleeding or when you can have pigmentary changes around the ankle. The third one is formation of an ulcer.
Venous ulcer
formation takes place. So usually whenever there is a complication, or if there are pigmentary changes, or if there's ulcer formation, usually surgery is recommended to be done at the earliest. Varicose vein surgery is never emergency surgery. Bleeding also can nowadays be stopped with medications and with medications being injected into the vein itself. So basically, previously when we used to do conventional surgery, that is the cutting open kind of surgery, we used to take the vein out. It was called stripping of the GSV.
Correct.
But almost for the past 15 years, more or less, it's come down significantly. Now we have minimally invasive procedures like laser varicose vein
Correct.
or radiofrequency ablation or injection of cyanoacrylate called as a vena seal. So basically what you do is you identify which are the valves which are damaged, and then you get into the vein.
How do you get into the vein?
So it's a percutaneous, just like how we put an IV cannula into your...
As simple as that.
As simple as that, under ultrasound guidance.
Okay.
You
So
put
you
a,
map it where it is.
yeah, and then you put a needle into the vein, then put a guide wire, put a sheath, and then you thread the device inside. That's a glass fiber in form of a laser. It goes all the way into the great
Oh, it
saphenous
burns
vein.
all the way up.
Yeah,
Oh.
and then you start, you come proximal to the place where it goes into the DVT, into the deep vein, so that you don't want DVT.
Correct.
And then you start obliterating the diseased vein.
You start burning it up,
Closing
it up.
Yeah. And once the procedure is done, then, if there are branch varicosities, then you give an injection called a sclerotherapy, and then you collapse those veins.
All those fat fellows will become small.
Will gradually start shrinking down over a period of time. So you also need to remember that, what has been there for years or decades doesn't go away in few days.
No magic.
It's the
But it does shrink.
It does shrink over 6 weeks. You're more or less normal. Since there is no cut involved, there is no significant pain.
Correct.
Not that they won't have pain, which will be managed with anti-inflammatory, and they can get back to work at the end of 48 hours. Can have a bath at the end of 24 hours. They'll be walking.
It's a daycare procedure like thing?
In many of the countries, it's done as a daycare procedure. And cosmetically, also, there are a lot of youngsters who come for these procedures as daycare. And I've seen it in some of the malls in the US.
Huh?
Yeah, they do this under tumescent anesthesia. And yeah.
Whoa.
Here,
it's reached that stage,
It's reached that stage because there it's essentially cosmetic in our country.
But who's doing? Vascular surgeons are doing it, or who's doing?
No, there are a lot of people. There are a lot of people who are trained to do it.
Oh, okay.
No, I would not say others can't do it. Anybody who's trained to do it.
Not quackery.
No, it's not quackery. Okay. Any person who's worked on it and who is
then it's okay.
Doing the right thing, I think
it's okay.
Should be doing it. Preferably vascular surgeons, because we are good in it and this is what we do.
Correct.
But there are a lot of other good specialists also doing this. As long as it's safe for the patient, I think it's good for the patient.
Correct. So before we go to the arteries, so I want to talk to you about the amazing organization that you had called JIVAS, Jain Institute of Vascular Surgery. And you just celebrated 25 years recently. So, I mean, more rather than me saying, let's hear it from you. And what is this that keeps this team buzzing? I see your whole team, different people from different, levels you have in your organization, but working like, a well-oiled machine. Everybody knows what they're doing. I am personally a recipient of that because, when you operated my mother and for the, arterial insufficiency, and so I was the caregiver of the patient, and both me and my mother were fascinated by the way your people took care of her. So one, thank you very much. She's doing very well. And we saw the attention to details. In fact, I keep telling my team that we have a lot to learn from the vascular surgery department as attention to detail that everyone is following, and not just people like Vivek is following. So can you tell us, how did you put this whole team in place?
Very fortunate in having a mentor called Dr. Suresh.
Correct.
I mean, Dr. Suresh and me and Dr. Vinaya, who's a clinical podiatrist, were the people who started this department 25 years back.
Got it.
We moved away from a different corporate hospital into Jain Hospital. And the management of Jain Hospital were very, very magnanimous and had the foresight to see that, vascular surgery could grow to this level.
You are saying now people don't understand 25 years ago, though it would have been crazy.
They had faith in us, and then being in a trust-based hospital, you're able to reach out to a lot more sections of the society or strata of the society than when you're in a corporate hospital. So the numbers started increasing. Our results were good, started getting better, and we formed a team. First it was Dr. Suresh and JIVAS, Vivek, Vinaya, then came Dr. Vishnu, and then came Dr. Sumant. Now we've got two more youngsters, Nikhil and Rahul.
Correct.
And you won't believe it, our team is the only unbroken team in the entire country. 25 years, and
Counting.
there is not a single person who's left us and gone.
Amazing.
So we
No,
feel thrilled
amazing,
about it.
amazing.
And it's not just the doctors. Usually doctors tend to take a lot of credit, surgeons take a lot of credit. If nobody gives it, we steal the credit. But it's always, any person who's worked in an organization realizes it's always the team members.
I
and
agree.
The background workers who really make it function. So we have foot care specialists, we have cobblers working in our department.
Cobblers, I think,
Yeah.
I mean, cobblers, and I heard you guys make 1,800 pairs of chappals every month, it seems, huh?
Yes.
I mean,
yes.
that's an unbelievable number.
So offering end-to-end solutions, it's not just
Literally,
vascular surgery, vascular medicine. We also take care of lymphatic edema, we take care of diabetic foot infections. And again, surgery is not the solution. It's just a part of the solution. It's the rehabilitation, which you strongly believe in.
Correct.
Is what is important. And we are, in spite of our best efforts, we are nowhere close to with respect to rehabilitation of vascular patients.
Which we will help for sure. We'll after this, we'll definitely take it on.
Look forward to your
we'll definitely contribute.
help with regarding to that. Then we realized that, we started getting vascular nurses and foot care specialists. And then we realized that, most of the diabetics have gait problems. They have lost their toes, unable to walk properly.
Peripheral neuropathy on top of that.
Yeah. And then finally, you've healed everything, and then the ulcer tends to recur. Why? Because, from being a medical problem, it's become a biomechanical problem because they've lost their toes and the weight bearing and the gait alters. So then we needed somebody to make good footwear for us, and turned out to be incredibly expensive.
Yeah, I know. Outside is very expensive.
Very expensive. So that was an interesting story. Initially when we started looking around for material to make footwear, there were two materials which were commonly used. Previously, MCR was being used. We found that Evazote and Plastazote were the materials which were needed to make the footwear or the insole. And if you had to look at it, it was very expensive to import it from US to make footwear. Then we found out that one person in Jigni was making both Evazote and Plastazote. And we were wondering what is he making it, and he is exporting it for. And we asked him, what do you use it? He said it's used for judo mats. So wrestlers and the mats on which they do is Evazote and Plastazote. And it's the same grade as what we use for footwear. Amazing. And we said, bring it on over here. Then we actually...
How serendipity sometimes just comes in.
Just happens,
Crazy.
And then we started employing some cobblers, and they've also been with us for 20 years.
Oh, that?
Yeah.
You started this was so long ago.
Yeah, so long ago. So that, we could offer... I'm not saying we are the best, but, we reach out to a large number of people just because of the cost part of it. May not look like, a good Skechers shoe or a Adidas shoe. Very functional, made for the patient.
And customized, they take the measurements.
For the
that's
patient.
The key. The key is that.
So, the other thing what I'd like to highlight is, we have another Dr. Girija with us.
Correct.
Who's again been with us 22 years. She is our vascular physician. She's also done a course in
she comes to the temple opposite our house regularly, so we meet her there.
Yeah, so she also helps in taking care of our patients very religiously, runs the OPD, and the go-to woman. It's not the go-to man, she's the go-to woman in the department.
Correct.
We are also very, very lucky to have another person who is a counselor.
Who's that?
Chetna, Dr. Chetna.
Oh, I haven't met her.
She's there in our department. So what happens invariably in medical, surgeons, we have problems with our attitude. We think we are at the top of the table or the food chain. We go talk to the patient. Hello, how are you doing? How's the pain, bleeding, wound good, everything fine?
Very functional conversation.
Yeah, and once it's done, you're okay. Get up and go. Patient has questions like, when can I eat? When can I have a head bath?
Correct.
When do I need to take this medicine? Before food, after food? And when we go there, the patient, I don't know, maybe they go into a sense of shock, or they don't want to ask simple questions and they don't have any answer to. So when our counselor goes, this prescription counseling, she tells them about dietary counseling.
Oh, she
So
is Dr. Chetana. She did that
Chetna-
to my mother.
Yes, 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 yes.
Oh, I didn't realize she
So
was Dr.
the
Chetana. Oh,
patients,
she was fantastic.
yeah,
I
absolutely.
was there in the room when she came, and I said, I just walked in, and she was so patient, so meticulous. She didn't get overawed by me being there. She just did that. I watched her for 20 minutes. I said, whoa. I mean, somebody's actually, I didn't even know JIVAS, but somebody was doing this.
Yeah,
I was impressed.
So very important, if somebody is building a good department, that you have people who counsels the patient, because irrespective of how friendly you are, there is a gap between a doctor and a patient.
Agreed.
The patient may not be in a position, or he might be drugged with painkillers, may not be asking the right kind of questions, and we are always 15 minutes late, either to the OPD or to the rounds or to the OT. So we may not be that careful in listening to what the patient. So we need somebody who listens to the patient and offers solutions. So we have various aspects of our
really
department,
all the small nuts
trying
and bolts.
trying to address people.
Very nice.
We have
Excellent.
people taking care of our non-invasive lab, Albert and Uday. Again, it gives me great pride to tell you that all of our department people are minimum 20 years in the department.
Amazing.
I wouldn't say
that takes something.
Yeah, I wouldn't say zero attrition. I would say 98% stay back with us.
I mean, that is we can probably write a management book on how you people have, because not easy, Vivek. Let me be honest about it. Because see, the egos are there. Everybody has a perspective to be done. So it's very important for us to know what's going on. Fantastic for that. I remember a statement you made when you were talking about Tata Steel. We also make steel. And why did you make this statement to me when you in the context of JIVAS?
So long back, I think if you remember when we were all watching Doordarshan, okay, so they used to show Tata Steel. They didn't want to advertise Tata Steel as making steel. They are into education. They are into running Tata Memorial Hospital. They are into cultural activities, Tata Institute of Social Sciences.
Correct.
I mean, the number of things they used to do helping the society in general was great. And when they gave an advertisement out, they highlighted on all those things. And last thing they said is, we also make steel.
Correct. I remember this ad.
So we also make steel.
Correct.
So we also do vascular surgery.
I love that.
Yeah, but we do a lot more things than just doing vascular surgery. So we are known as vascular surgeons. So I'd like to say that, we not just do vascular surgery, we do vascular medicine.
And so much more, as
and
footwear to everything
foot
else.
care,
True.
Counseling, swollen limb,
amazing,
reaching out to people and going to medical colleges, teaching them about vascular surgery and enticing students to come to vascular surgery, because we want our tribe to grow.
Correct.
And then, I think, our biggest...
more than grow. India needs, thousands of people more than this.
Absolutely.
Because,
it's strange, a country of our size has around, at the moment, has around 600 and odd active vascular surgeons. That's all.
They're less than neurosurgeons.
Absolutely.
Whoa.
Yeah. And
obviously much more is required than what we are.
Much more
is required.
And
600, Vivek?
That's all.
I can't even imagine.
Yeah, 600 and odd is the present count.
Goodness.
So there are whole states of India which do not have a single states. So southern part of India is very, very lucky and progressive in having a lot of vascular surgeons in each of the states.
Then you
but
can
there
imagine
are
the
whole
halat of the patients there.
Northern India, Eastern India have a deficiency in vascular. So our endeavor is to train more students.
I mean, hats off to you. Hats off to you.
And when you say that, we also make steel, I always keep telling my students that, sometimes I'm harsh with them. Not sometimes, most of the time. But I tell them, a sword is a sword and nothing can beat a samurai sword.
Correct.
And it's not because it looks good and it's got steel and it cuts well. It's tempered for 7 years before it reaches that stage. So anything, if it has to be long-lasting and work efficiently, needs a little bit of tempering, both by heat and by cold. So we pamper our students, plus we are a little, I would say, strong on them, so that they get the best out of learning.
I second you. I think the training has to be ruthless, Vivek. I'm telling you. If I always tell my juniors, if your training is not ruthless, your practice will be ruthless and you will get kicked every day. you have to come out as a champion. If you don't come out like a champion, there's no point, especially in surgery, because you won't get a second chance to go and figure it out what is happening more often than not. So I agree with you guys. Vivek is being very modest. JIVAS in Jain Hospital runs probably the best vascular surgery training program in the country. They got the number of gold medals. I don't know how much, 15 now? It's amazing the number of gold medals they get. It's a very sought after place. The kind of volumes that have is huge. The kind of high end work they're having is huge. So all those people wanting to be vascular surgeons and do it in your state to help your community, please reach out to him. He'll be more than happy to, if there's a slot to get you guys in. 600 is nothing. It has to be 6,000, maybe 10,000, much more than that is required for sure at the end of the day. This is what you do. So teamwork, training, so mentorship is one thing. And I also heard that you have a fantastic simulation lab in your, training place as you empower your people. So I know very few places have a simulation lab like this. So can you tell our viewers, as you see the video playing on the simulation lab, can you tell us what is this lab and why is this important for the training of a vascular surgeon to be complete?
So we have 3 sets of students in various stages of their career. So usually vascular surgery training is for a period of 3 years.
Okay.
And
that is after MBBS?
After MBBS, after doing their masters in surgery.
So after MBBS, they did 3 years MS.
MS,
and then
like
a neurosurgery, it's a 3 years.
It's a 3-year course in vascular surgery. So when you have to train these people on doing blood vessel surgery, learning on the patient directly is what we did. And
Correct.
there were mistakes being made, and who pays the price? It's always my mentor who's by my side who corrects the mistake. So we thought, let's try and focus on teaching our students without making the mistakes or minimize the mistake.
Correct.
Minimize the mistakes as much as possible. So we have a simulation lab. So
like a pilot simulation cockpit.
Similar to that. We have a full-fledged simulation lab. It's not only that, we give them hands-on training with grafts and blood vessels derived from animals, of course, treated, so that they get the right hang of doing things. And then we have a 3D reconstructed model. So where we teach them endovascular skills with the Indian setting where, you don't have access to lot of things which you can keep using over and over again. So what we have, how do you do that? And then we have the more advanced computerized navigation system, which actually, you can do the entire procedure and at any stage.
Literally as if you're doing a real surgery.
Yeah, you give the case scenario over there, like what you're encountering, you feed that data. So before you put the patient on the table, you do the entire endovascular repair using that. It tells you these are the things that you did wrong. So you use the wrong wire, you use the wrong sizing of the balloon, you use the wrong stent, or it tells you if you've done it right. And if the mistakes are less than so much, then we can confidently tell our student that, since we've, it's the same CT scan of the patient which is put on the computer and then you simulate it. And if he knows how to do this thing, then I am confident in telling him that, go ahead and start the case, I'll be coming.
Got it.
Or I can, just keep monitoring him. And so this is what we've tried to do to value add to our students.
Very good. Fantastic.
And
it's very important. I think so.
I think that's how all institutes are going now.
You guys have always been setting the trend, starting it early, including the hybrid cath labs, which we'll come to that. So you see, it's not only he's short of hands to treat patients, they're doing end-to-end, including all those things. Vivek is heading this whole thing. Apart from that, they're investing their time to train new people because this country needs thousands of vascular surgeons to be able to help the patients get better, more efficiently.
Absolutely.
So amazing. So now we move to arteries. So we spoke about the veins, 2 major conditions, which is the DVT and the varicose veins. I know certain other small things, but we'll not address that. We'll go to the arteries. You said artery, except the heart, except the brain, you guys deal with everything else. National Vascular Day is coming in August, and you have a commitment to what is the motto this time is Amputation-Free India. Amputation, guys, is cutting the leg at different parts or whatever it is. So how can we not cut the limb anywhere is what they're committing to. It's a large commitment, let me be honest, and very courageous commitment. So obviously that means you cut it because the blood vessel supply is not going to, and that gets dead or infected. So amputation for that, why does the amputation happen? And we'll go into the arteries. Maybe that's the right connection I'm feeling.
Okay, regarding Amputation-Free India, the campaign for which we've launched.
You did a marathon also
Marathon
recently.
And a walkathon.
Walkathon, sorry,
Okay. So it's like this, India has the highest concentration or highest population of diabetics in the world now.
Yes.
We've overtaken China there too.
We have all the wrong medals we are having, not the right medals.
And our habit of barefoot walking,
okay,
both at home and outside, makes us more prone for developing small infections
in the foot.
Small injuries in the foot, which tends to get neglected, get infected. And if you're a diabetic who's poorly controlled and there is infection in the foot, and if he by chance happens to have decreased blood circulation, it's a recipe for a disaster. They end up losing their legs, either below the knee or above the knee. Yes. So, and this also is a preventable cause.
Correct.
Again, a stitch in time saves 9. Correct. So if you look at it, if you attend to that condition at the earliest stage when he sustains an injury, try and arrive at that stitch in time, can be treated easily. And if you can advise him, a diabetic patient, to wear footwear, that's all we're saying, wear footwear, you can prevent a diabetic foot infection.
So simple.
It's so simple. You don't need any of the fancy
stockings for DVT. You wear this. I mean, you're not even giving tablets. You're just such a simple non-pharmacological. Yet people don't follow it.
We don't follow it, including educated people.
Why is such a fatalistic attitude we have? I just don't understand.
I really don't know. But society needs to change, and there has to be
educated people.
Yeah. So I would contradict you over there. We are very, very literate, but we are not educated. We know how to read and write.
I know.
But we don't apply what we read and write.
And everybody has a 5G phone, 6G phone. They have access to all useless information. They don't, get the useful information.
All they need to wear is footwear. You can prevent an amputation from happening. Not just an amputation. To treat a diabetic foot infection or to treat gangrene and prevent an amputation, once infection sets in, you need money which just flows.
Correct. And time also.
Yeah, absolutely. It takes months together. Takes months together. So if we can prevent it, that's the whole thing of try and prevent amputation from happening. If they get injured, try and treat it at the earliest. If there is a correctable cause, so among the correctable causes, the only correctable cause is improving the blood circulation. You can't change neuropathy.
Correct.
You can't reverse neuropathy, but the blood vessel blockage can be reversed.
I have seen your podiatry people actually showing people to keep a mirror and look at what's happening, because you can't see the sole of your feet, so they're teaching people. So just keeping a mirror at your house, or all diabetic patients especially walk barefoot to see. These are all very simple things to look at, how to do it. Thank you for saying that. Join Dr. Vivek and his team to make India amputation free, guys. All of you take care of your blood sugars and you take care of your feet, take care of circulation. That's what it is. Yes, Vivek, you can go back to your peripheral vascular. So Vivek, let's go to the arterial system, the other side of the vascular tree. Can you educate our viewers about the arterial system that you guys handle and the diseases that comes with that and how to catch them?
Okay. Arteries are the nutrient vessels that supply blood from the heart right down to the scalp or to the toes.
Correct.
It's like the rivers. Life depends on what the arteries give to the tissues. Like I told you, we deal with all the blood vessels other than that inside the brain and inside the heart. So to give you a brief overview, it's pretty complicated. So we start with the neck. Blood vessels in the neck, if they get occluded, can result in a stroke, which I'm sure Sharan has already described in previous episodes. That's called as a brain attack. Blood vessels going to the upper limb can get blocked, giving rise to gangrene or ischemia of the fingers.
Which become blue, black.
Yes. Occasionally, you have a congenital condition called as a cervical rib, which is an extra rib. Lucky or unlucky, we don't know, but invariably it damages the blood vessel, that is the artery, or sometimes it damages the nerve. that also needs to be repaired. So atherosclerosis, that is the reason why arteries get damaged, can result in two events. One, usually for majority of the people, the blood vessel slowly starts getting blocked, like what is shown in that plaque out over there. So it's called atherosclerotic deposition, causing narrowing of the blood vessel. And once the blood vessel gets more than 70% narrowed, the concerned tissue starts getting decreased blood supply,
Starts crying.
And starts getting damaged.
So 70%. So
70.
that much the body adjusts.
It's got tremendous healing capacity.
Tremendous.
And the other way atherosclerosis happens is when it starts ballooning out.
Okay.
So that's called as unresumal dilatation.
We are small in the brain, you guys are big ones.
Yeah, we have big ones. Like I told you, upper limb. Then we have the blood vessels in the chest. So occasionally you have coarctation of the aorta where the aorta is narrowed. Otherwise you can have aortic aneurysms. And then comes the infradiaphragmatic part of the abdominal aorta. Abdominal aorta, you can have aneurysm, which we start dealing with, and then you can have occlusions. And then you have a whole lot of blood vessels going into the intestines, into the stomach, and into the renal arteries. All these vessels can start getting blocked. So
same funnel like how it gets blocked in the heart or brain.
Same. So similarly, you start coming to the lower limbs. You have blood vessels getting blocked in the lower limbs, giving rise to ischemia or giving rise to gangrene. So basically, arterial system, once the blood vessel starts getting blocked, it attacks one particular organ. Like we discussed earlier, you have a brain attack, occasionally you have a lung attack, then you have something called as a gut attack. If the mesenteric blood vessels start getting blocked, it creates a gut attack. And when it comes to the lower limbs, that's the most common in our country, especially with increased incidence of diabetes. The lower limb blood supply start getting blocked, and then they start getting gangrene of the toes. And that invariably is called as a leg attack. That means similar pathology where the blood vessel is getting
location
blocked.
Is different.
The location is different.
You caught my mother early and that's why she did well.
Yeah, so this is in brief about what can happen. Usually it can get blocked, giving rise to ischemia or infarction or death of tissue, which is called as gangrene. Or it can cause dilatation of the blood vessel, also called as unresumal dilatation.
Even in the leg you can have an aneurysm, or it's only mainly in the aorta?
Not necessarily only in the aorta. You can have aneurysms of the femoral artery, popliteal artery. Okay. And in our not only in our country, all across, with increased amounts of interventions being performed, you get a pseudoaneurysm also.
Correct.
Iatrogenic or pseudoaneurysm.
Correct.
So these are the kind of pathologies that we regularly deal with.
Got it. So again, as you had mentioned in the beginning of our conversation about the medical management, obviously you must be having a similar medical management for this before you go into the non-medical, that's a surgical or whatever it is. So how important is medical management for a peripheral arterial disease, as what we call? So is it different for different areas that you described, or is it common?
So atherosclerosis is the same in whichever part of the body.
Correct.
So medical management forms the bedrock of treatment of any form of treatment. So you always start the patient on medical management. So in his case, most important is lifestyle modification. Smoking cessation, if it's there, is the most important component. Otherwise, any form of treatment without stopping smoking is not going to give durable results. Good lipid profile control, as well as diabetic management. Cholesterol, triglycerides, and good diabetic management. And then we go on to dietary modifications. Then we go on to the medicines. So basically the medicines what we usually use are blood thinners. It could be in form of antiplatelet agents, or it could be in form of anticoagulants at a lesser dose. Then we add statins to reduce or modify the lipid profile. Statins, very, very important for us because it not only stabilizes the plaque, it reduces the plaque size also
Oh, I see.
over a prolonged period of time, especially documented in the carotid artery, including the intima-medial thickness starts coming down with appropriate usage of statins. And then you have agents which improve the blood circulation. Few drugs like silistazole or pentoxifylline. I mean, pentoxifylline, we've been hearing it
Correct.
and using it from our college days, literally 2 decades or 3 decades away. These are drugs specifically used in patients who have claudication, earliest stages of arterial insufficiency. So when we say claudication, the patient is able to walk for around 100 feet and then he starts getting calf pain. He rests for some time, then he starts walking again.
And then he stops again.
So in these people, if you start them on medical management as well as dietary modification and risk factor modification, you can get away without the patient going into gangrene, or we don't have to do any kind of intervention.
Got it.
Medical management is very, very important.
Just to add here about claudication, so we also have claudication in lumbar spine called neurogenic claudication. So one of the things we have been trained on is the moment patient comes with what seems like claudication symptoms, the first thing I look for is the dorsalis pedis pulse. I want to make sure the arterial system is okay. Otherwise, that's more common than the neurogenic claudication. Only after that we look at is it the lumbar spine and then look at it. So we have a claudication match and we look at both. Sorry, please continue.
Yeah, so like how you said, this is a common area where, patients come to neurosurgeon or comes to a vascular surgeon thinking it's the other specialist. So just like how you feel for the pulse, you're a good neurosurgeon. We do something like, we find a pulse and we don't know whether, we know it's not arterial. So we do a SLR and if we find that there is some problem, refer to the neurologist or the neurosurgeon to do the needful. So we make sure that, we haven't missed the arterial system. I think, a good physician, patients don't know which specialist to go to.
Correct.
They trust somebody and they go there. And even if that person is not able to give them a solution,
you should know
send them to the right person. So I think that is where a family physician makes a
big difference.
Big difference, and he can guide the patient instead of the patient running around between various specialists.
Got it. So you said about the medical management and how important is exercise in the early stages? I mean, and what kind of exercise, if at all?
We have 2 sets of exercises, one for the arterial system and the other for the venous system. Okay. For the arterial system or venous system, nothing works like walking. So when you start walking, this is when the patient has claudication. Not once gangrene already sets in. Then you can't do anything. You need to restore the blood circulation. When the patient has claudication, in addition to the medicines and lifestyle modification, walking is the most important part of lifestyle modification. If done supervised exercise program, when you make them walk on a treadmill, so basically you're conditioning the rest of the blood vessels to supply more blood through a system called as the collaterals. And then that usually takes around 6 or 8 weeks to develop or to get strengthened. So walking is very, very important.
How much is there a recommended walking?
Don't listen to the doctors. Listen to the patient. The patient leg tells you when to stop.
What do you mean? Can you give
it's like this, depending on the amount of blockage that is there. Sometimes, a patient can walk for 500 meters or half a kilometer and then he gets the pain. So when he gets the pain, wait for some time and restart walking. So I can't use that to every patient. There might be another patient who can't even walk for 50 meters. So I can't tell him to walk for 500 meters. So once the pain happens, you stop for some time so that all the bad blood, good blood circulation is restored. Get back to walking again. And then gradually increase it.
And the end point always, the stop is the pain and then give rest and then stop. So even if he does this start, stop activity, how much is there like everybody says walk 10,000 steps, walk 8,000 steps, half an hour, 1 hour. Is there some formula that you have over time that you have seen will make sense?
If these guys can walk without pain for 15 minutes or 20 minutes, we'll be extremely happy.
Oh, God.
Now, 10,000 steps, all that is for... a normal ambulant person.
But even 15-20 minutes if they walk, you are happy.
Again, like you say, we want them to be functional first.
Correct.
even a 20-minute walk without
Perfect.
pain, will be very happy. This can gradually be increased.
Correct. But at least the first stop is 15-20 minutes with breaks, whatever it is. At least they get an effective 20 minutes of walking is a good start from what they can get. Perfect. So, assuming that the patient, thanks to their a good team like yours, gets the right follow-up, right management, they do their job, you do your job, all the medical managements be done. Yet, there's a percentage of people where the disease does not listen and goes beyond the medical management perspective or a failed or, resistant to medical management. And that's when the alternate things come in. So what are the changing trends in the non-medical management or the surgical? I don't want to use the surgical because there's so many other things going on. For the non-medical management of peripheral arterial disease, once the medical management fails.
Okay. Over the past 2 decades, treatment of peripheral vascular disease has undergone tremendous changes like any other field.
Correct.
But to keep things very, very simple, it's like if there is a long segment of the blood vessel which is blocked, you need to restore circulation.
Correct.
So to restore circulation, you can do one thing.
You can the pipe is blocked. I want to get the water back inside.
You can clean up the existing pipe.
Okay.
Or if it's beyond any stage of repair, you create a new road. So you put like a different pipe. It's like a bypass surgery. Or that's what we used to do when we started. Majority of our practice used to be doing bypass surgeries for the leg or in the abdomen.
So guys, bypass is not just for the heart. Bypass is done anywhere an artery is blocked and you can restore circulation.
Yeah, like the term says, it's a bypass surgery. Something is blocked, so blood has to reach the next destination.
Alternate path.
So you provide it. We usually use the patient's own vein to create
again the leg veins only.
Yeah, the leg veins.
So again, the varicose veins managing guys become very important because those veins have to be in fit shape. In case, unfortunately, you develop some other problem that can be used.
If once the patient develops varicose veins, you can't use that vein.
Correct.
Then we end up using artificial conduit, not as good as what God has given us.
Correct.
So we end up doing a bypass, restore circulation. If many a times, our patients are very sick. Vascular patients are some of the most morbid patients.
Why?
Diabetes, renal impairment. 70% of them have either had a stroke or they've had a heart attack. So atherosclerosis is a global disease. It's a global disease and it's manifesting in the foot. But please remember, we are only addressing one part of atherosclerosis. So they have very high incidence of cardiovascular or cerebrovascular mortality or morbidity in the post-operative period. So if the patient is very sick or if the lesion is quite small or limited to a small area, then we end up doing what is called as an endovascular procedure where you do an angioplasty.
Like how the cardiac guys
Similar procedure. So you just clean up the pipe from inside. Previously we used to do an angioplasty. Sometimes you put a stent, sometimes you don't put a stent.
So without a stent means what? You use a balloon?
You use a balloon. Balloon stands, is the basic of doing an angioplasty. So you basically break the atherosclerotic plaque and improve the lumen.
It's what you did for my mother.
Yeah, so that the blood flows through. If in spite of doing it, if it's grossly calcified, the vessel tends to collapse, then to hold it in place, you use a stent. Now the recent advances, what are happening is, stent has a limited lifespan in the peripheries.
Okay.
So what happens is majority of the stents at the end of 2 years or 5 years or 7 years get blocked. They get blocked. So what they say now is, leave no stent behind. Don't leave a metal inside the artery, especially the femoral artery, the one in the thigh. So you have various devices. So it's atherosclerotic plaque which is causing this kind of. So you have devices which will scrape out. It's called as a atherectomy devices.
Intravascular.
Intravascular, yeah. So you go inside. Yes, literally like a tunnel boring
machine.
You have it
in...
No, we have to. No, we've used it in our center. We've used it in our center. So it's a disposable device.
Interesting.
So you just go inside. There are a lot of new devices which have come in now. Atherectomy devices. So Jetstream, Silverhawk. So these are things which go inside the blood vessel, clears up the clot.
But it doesn't damage the intima, the
inner portion. No, it's designed in such a way that it doesn't damage the normal tissue. It only tries and scrapes out
Very interesting.
the atherosclerotic or the severely narrowed segment.
Correct.
And this is
That is
all
the one
done
which
under
calcium or the
absolutely.
cholesterol,
Cholesterol
that's
deposits.
blocking inside.
Yeah, so these are the new advances. Yeah, costs are little high, but tremendous amount of changes taking place in the field of vascular intervention.
Amazing.
The other thing,
And
what
it doesn't
we've
matter
noticed,
how long the segment is?
yeah, then you sometimes you might end up using 2 devices to clear up the whole segment.
Okay.
But invariably one segment.
That thing has
that has a lifespan.
Okay.
Or it can take out so much of calcium. If the lesion is very, very long, preferable to do a bypass.
Simple.
Preferable to do a bypass, lasts longer. It all depends on how morbid or how sick the patient is.
What kind of, how long and complex the procedure that you can do and what the goals of the whole exercise is. Are you saying that they are so sick, they are so morbid when they come to you because these people don't understand the vascular problems and they neglect it and come late, or why is they're so sick?
It's just the disease process with multiple organ or multiple arterial beds which
they happen earlier than this, and so they're already sicker.
Yes. So atherosclerosis happens in everybody of us.
Agreed.
Okay. So how we die is because we all die because of atherosclerosis affecting different parts of the body. It's not how old we become. It's how old the arteries are.
Correct.
If it affects the heart or the brain or the legs or the abdomen. So finally, atherosclerosis kills us. So with medical management and with proper uses of either surgery or endovascular techniques, you can postpone the inevitable by a few years. But with newer advances, we are gaining good results in saving the limb. I won't say we are going to increase the overall lifespan of the patient, but the quality of life in a patient who is prevented from having an amputation is far superior.
So all these are goals to reduce the amputation
and
go towards your goal of an amputation free, apart from the earlier, all the other things that you said. So suppose, I know this is still a newer advance and things like that. Suppose a stent gets blocked or whatever you said, So can you remove a stent and put a new one, and then, or you have to only do a bypass after that?
Not necessarily. Now, again, you have various devices where, what blocks a stent is actually something called as neointimal hyperplasia.
Correct. So something goes through the stent.
Goes through the stent struts. So we have devices which will go inside and suck out all those things. And then you do angioplasty and put one more device.
Amazing.
So
how much technology has got ingrained into us, especially a surgeon's life, is just incredible.
Yeah. So
amazing.
Again, we are getting better and better at our plumbing techniques, and new devices are helping
Vivek
us.
Is, simplifying it is saying by plumbing technique, don't take it at that. It's very complex. If you come and see what they do, it's incredible.
No, the principles are the same.
I agree.
The principles are the same.
I agree.
It does work. But again, what exactly to choose for the patient is left to the decision of vascular surgeon.
The wisdom.
The reason why we say vascular surgeon is, we do both vascular surgery as well as endovascular procedures. So if the lesion is complex.
So vascular surgery is when we open.
Yeah, when we open and do a bypass. So there's one segment of the artery which is blocked. So we bypass from above to below. When we do endovascular, we can only clean up the pipe from inside. Many a times we are not able to do it. So we are in a position, if we are not able to do endovascular, alone, we are able to do a bypass also. And we decide what is best for the patient.
Or it can be a mix of both also.
It can be a mix. So we do a hybrid procedure where we do a combination of open surgery along with endovascular surgery.
And that's what you do in the hybrid cath lab, which was one of the first in the country or second in the country.
Second in the country. When we first opened our hybrid cath lab almost around a decade ago, more than 11 years ago. So this is a cath lab which was initially being used by cardiologists only to image the heart. But then we realized that, that cath lab can't be used for the peripherals. So we need a different II, different sized monitor, and the table has to move to come all the way down to the toes. Whereas a cardiac cath lab could not help us visualize below the knee joint. So, and many a times, they are not designed to take a surgical case.
Correct.
So we started needing those kind of cath labs, which are called as hybrid cath labs, where you can do a surgery also, as well as you can do endovascular procedure.
Moving the patient from
instead
this
of
side
moving
to that
the
side.
patient.
Got it.
And Jain Hospital is one of the first places which got it. And again, I think we've already placed the order and we're getting delivery of the
I know the new
latest
I agree.
cath lab, which
I'm
is
looking
really
forward
high
to it.
end.
I know, I agree.
And I'm sure you can use it too in your neuro intervention cases.
Of course, we are excited.
So
We share the cath lab. The cardiologists have their own. We have our own together.
So that's how imaging. So I think technology is
Big
helping
enabler.
us. Yeah,
Big enabler.
Yeah, is helping us giving better results to the patient.
Not only helping us visualize better and more accurately, and also access with minimally invasive, maximal benefits and things like that. I think that's making a big difference. Yet, guys, don't think that Dr. Vivek has a magic wand and he can do Chumantrangali for what it is. You have to go back to fundamentals, take care of your lifestyle, your habits, and all of those things. That's fundamentally what has to be done. Don't think that you do all the rubbish and then come and lie down here and he's going to do something and you're going to walk out, like a brand new car. It's not going to happen. It's not going to happen to a car. It's not going to happen to you.
Other thing what I'd like to tell is, 20 years back, 25 years back, when we used to do revascularization, it was essentially 90% or 100% surgery.
Open surgery.
Open surgery. Aortas, renals, lower limbs, everything was open surgery. Upper limb, carotids.
So long incisions. Huh?
Incisions, harvest the vein, bypass. Pretty good. It still remains the gold standard. But now, over 20 years now, it's more or less 70% of our work in our institute, which is endovascular. That
70 is endovascular.
70% is minimally invasive and 30% is open surgical. And we choose what is best for the patient.
And a hybrid if wherever needed.
Yeah. And we've noticed over so many decades that minimally invasive surgery definitely reduces the mortality as well as the morbidity. So different ball, different strokes. So you can't keep playing the same stroke for all the patients.
Yeah. So like he said, everything has two sides to it. So he's telling you the good side as far as the patient is concerned. Now I'm going to come and pin you down with what is your risk when I say you as a vascular surgeon, exposing yourself to so much of radiation every single day. What precautions are you taking? What is your risk? I know you're putting your life on the line to save the patients, but you also have to take care. You have a family, you have to take care of it. What is that you are doing and to you and your team to see what is the protection that you take from radiation? Because radiation has its own hazards.
Radiation safety, unfortunately, is taken for granted. We all think that, if we wear the lead apron, we are protected from the ill effects of radiation.
But I see you guys only till here. He's not protecting the head also.
You're not protecting the head. You're not protecting your eyes. Though, you might be wearing radio opaque lead shielded glasses. Our hands are not protected. Leg is not protected. So, and the other thing, the difference between what happens in our country and what happens in many of the other countries, including China, I was surprised that, everybody other than the patient goes out when the main procedure is done. And it's all done remotely.
Really?
Yes, that is what is happening.
Are you?
Or
you mean robo-assisted?
Not robo-assisted. The same, So the main surgeon stands behind one complete station.
Like the X-ray guy gets.
Yes. Huh. And then he does the angioplasty from behind that. That keeps moving. The anesthetist is not there inside the OT. The nurses are not there in the OT. And any of the surrounding staff are not there in the OT. So we still haven't reached that level. We haven't reached that level. Partly we are to blame. Recently when I attended a meeting, so when they came to know the amount of surgery that or endovascular procedures we are doing, he said, Vivek, if you're above 55 and if you're doing all this, he said, it's foolish. He says, the ways of protecting ourselves from radiation side effects, we are still at a primitive stage. We are looking essentially at the physical barriers.
When you say we, you're saying India?
All over the world. All over the world.
And you don't even know probably.
Yeah, we don't even know how it's affecting
You're
us.
assuming I wear the lead apron, it's fine. Yes. You don't even know whether the lead apron has a safety or it has an expiry date. Nobody has a clue what's going on. Alva?
We do not have proper quality checks. We all like to say that. Our scalp. Then we started, realizing that, your eyes also.
Oh, that glasses you wear is the radio glasses.
Yeah, So, and then sometimes, then you need to realize that, not we realize, the industry itself realizes that it's not just this. Then you need to look at these other marrow producing bones.
Correct.
So
Bone
these
marrow
are the
suppression.
bone marrow suppression
Correct.
or leukemias are
Crazy,
more in these
crazy,
people.
crazy.
Then you started getting lead impregnated gloves.
Oh,
Who's going to pay
made
for the lead
exact.
impregnated gloves?
Because it has to be disposable, alva.
Yeah, it has to be disposable. So in our
Crazy,
country, we
crazy.
still are. So yeah, I'm sad to say that, I do not follow, or I'm unable to follow all the precautions.
Ideal norms.
Yeah, it is difficult. You operate under various constraints.
So guys, what Vivek is trying to say is that the focus has been so patient centric to get things better for them, to save the life of the patient, and get the better outcomes with minimally invasive and all of the best technology. The technology does not come without its risks. Yes, the patient is exposed to radiation for only that one, his own procedure. But here, these guys are doing three a day, 5 a day sometimes, and it's crazy the amount of radiation there. It's not an X-ray. They are like on a fluoro, continuously imaging huge amount of radiation. And it's like it's the risk that the guys on the border have, the soldiers, and you are having. I don't see any difference at all. And and neglected, you're not worried about yourself because you feel the patient is more important. But I think you guys are, because eventually it's very important to take care of
No,
yourselves.
all the concessions we make against our body, we'll have to pay for it.
Allah, I mean,
We'll have to pay for it. And I urge all our hospitals and medical professionals who are using radiology equipment to be a little more careful with yourselves.
I think the diagnostics are much less at risk than you guys. Alva.
Absolutely.
Because they're not like hands-on. They can be so far away, and it's not so complicated at all. Oh, that's but you get that thing that Bark
The
asks you to
dosimeter.
wear.
Yeah. So we do use it, and it just tells us that
Oh, but you don't know how much penetrations happen. That's right. That's a very different game altogether, alva.
And that is very localized to the area where you're using it. No, it is needed, and it needs to be they check on how much you've been exposed to, and if they find that you've been exposed to more than
then
what
you have
should
to
be,
stop going
you
in
need
and
to
all.
stop going into the OT for a couple of weeks to couple of months. Yes, there are regulations, there are some protocols being followed, but I think the way hospitals are going, the way insurance is going,
Nobody
with,
cares.
with
Everything
cost
money,
cutting,
cut, without realizing administrators have no clue what's the risk that we are going
the
through.
cost cutting which is happening, and like you said, everything is patient centric. We are not taking care of our nurses or our healthcare professionals.
Yes, I was going to come to that
as
next.
much as we should be. I like arguing. I like giving a contrary view, like many of my friends, especially my dear friend Vishnu, Dr. Vishnu, who's also a vascular surgeon, who always gives a contrary view to anything you say.
Oh, I have not seen that.
Yeah.
Oh, I have not taken.
Yeah, he is a completely contra man.
I see.
Though he believes the other way, but he likes to give his contra. So I started what is called as a debate club.
Okay, I didn't.
So
okay.
where and the theme of the debate
is
club
pro and for for and against. Correct, in school.
So I started. We called it taboo topics.
Okay.
So there are a lot of topics which are not discussed in various forums.
Okay.
I mean, it's just
give an example. Just an example. Just for our viewers. Taboo. What is taboo?
It could be about gender discrimination in surgical profession. How difficult or it is for a lady to succeed
great question.
in vascular surgery or in surgical field.
Even neurosurgery.
Yeah, even neurosurgery.
Even neuro, for a long time, we used to tell women not to become neurosurgeons. Today, we have 250 lady neurosurgeons in the country. So, Vivek, the extension to this, you just mentioned nurses. Even all of them are young nurses. They're going to get married. They're going to have children. Is there any data to say what are these girls, the young women getting exposed to this? Is there infertility issues, other issues more than those who don't work in a cath lab like setup? Is there any data at all in the world to tell you this?
Yeah, unfortunately in India, we are always, there's a paucity of good data coming out. But there was a study done in Germany, this was almost around a decade and a half back, which did say that, people working in the cath labs had some amount of infertility issues and little bit of or they observed that the genetic abnormalities in these patients were a little higher, but then finally they said that it's not statistically significant.
That
so it was sort of pushed away. But then the German Nurses Association did bring it up to hospitals to make sure, invariably what used to happen is, it's the doctors who get the best laid aprons and the nurses are left to do with not so good ones. So we need to try and insist that, everybody gets
The same kind of
the same kind of protection devices which are there.
So are you trying to monitor the number of cases per week, or is there anything like that at all happening in the department, or
No,
you are able to pull out
do try to at least I
sort of
personally
distribute the
I personally try to make sure that everybody's exposure time is kept to the
as much as you can inside of the
lower period. Try and send people out because there is everybody wants to see the procedure and learn how to do it. Whether it's the nurse,
yeah.
they want
So
to
the
get
guys
trained.
who are learning also are simply
They're
getting
also,
exposed
they're standing
without even
over
doing
there.
anything.
Yes.
Your
So,
students,
the
crazy.
students and
You're right.
observers. So there are a lot of things,
I know.
in this.
Like the devil in the deep sea agbidutte, alva.
I
You have to be
both
close
are the
by.
same. Both are the same.
So now let's focus on an area which is, an overlap area for both of us. But I think one of the most critical areas, I believe, because it goes to the brain, is the carotid arteries. So carotid endarterectomy is something that you guys do well, that I see. And also, you also do it for many of our patients. And also you do a carotid stenting, I'm quite sure about that. So can you tell our global viewers that, if there is a critical stenosis in the neck, which is very different from what happens in the periphery, because you don't really do a bypass here, we do have to do other things. What is these two procedures, a carotid stenting and a carotid endarterectomy?
Okay. Before that, I'd like to give you a brief history of what carotid endarterectomy
Sure.
is.
I would love
And
to hear
before
that.
that, so the most common cause of ischemic stroke, I think you've attended it in some of his previous
Correct.
lectures or sessions.
Dr. Anil Ramakrishna has spoken about ischemic stroke.
Yeah, so it's a ischemic stroke where a small clot goes into the brain and causes blockage of the smaller blood vessels of the brain. So the source of the clot can either be from the heart or the aorta, or it can be from the carotid artery.
Correct.
Carotid artery is one of those areas where it produces these atherosclerotic plaque.
Correct.
Once the plaque hemorrhage sets in and then it ruptures, it throws in clots or small cholesterol crystals.
Why does that happen? Because the cholesterol thing and then the blood going on top of that gets damaged.
There is something called as a shear stress.
Correct. Yeah.
At the bifurcation of the carotid artery, shear
when
stress.
It becomes internal and
yes,
external.
external. So once the lesion crosses 70%, and it's the cholesterol deposition and the lipid
triglyceride and all of those things.
production which happens from the smooth muscle cells, it starts accumulating and then it reduces the lumen. But just reduction of the lumen does not cause a stroke. It's when this plaque ruptures.
Correct.
Because of intra-plaque hemorrhage. It is when it opens up like a volcano.
Like it bursts.
And then it throws debris all the way across, which results in a small stroke.
Correct. Small, big depends on how big the size of the debris.
So usually these patients have a warning in form of a transient ischemic attack.
A warning stroke, reversible stroke.
Reversible stroke. So it's called as a TIA. They have slurring of speech or some amount of
numbness,
weakness,
which sometimes
or a little bit transient blindness, which just goes away, and then absence of grip or something which stays for a very short time and goes away. And invariably you think, oh, I was feeling weak or I did.
And they neglect it.
They neglect it. And then everything in the body gives a warning.
Correct.
Body is a wonderful healing machine. It gives you a warning.
I agree.
And you don't listen to it. If it throws a bigger clot, you end up with a full-fledged stroke. Carotid endarterectomy was first performed in 1951. Actually by a guy called Raul Carria, who's a neurosurgeon in Argentina.
Oh, I see.
Okay. So at that time,
it's opening the blood vessel here and removing the cholesterol physically.
So those days, there were no endovascular procedures. So you literally had to go inside, go into the blood vessel, clamp the artery, open the artery, take out all the atheromatous plaque, and then close the artery and try and maintain the circulation. So it was actually performed in 1951. Then 1953, okay, this is where the controversy starts. Debicki performed the first carotid endarterectomy, according to him and his team. And Eastcott, but it was not published. Eastcott was the first person who published it in 1954.
Oh, so he got the credit.
He got the credit, and actually DeBakey was something like a mentor to Eastcott.
Mm-hmm.
And then he said, everywhere it's mentioned as Eastcott. So it's taken. But there are a lot of controversies because the French surgeon said that they have done it before. So the basic principles were, if there is atheromatous plaque, which is beyond 70%, throwing emboli into the brain, take that plaque out.
Correct.
So then you had the NASET study and the ECST studies, which said,
Correct.
Beyond 70%. And initially, when they started doing it, the mortality and morbidity was as high as 20%. Post-operative stroke.
I can imagine.
Now, over a period of 3 decades, 4 decades, now carotid endarterectomy has
come down significantly.
Significant reduction in intraoperative stroke. So it's come down to as less as 2.5%. That means
I think the distal protection device has probably made a big difference.
Yeah, no, when you do a carotid endarterectomy, so you don't have a distal protection device. That happens only when you do endovascular procedure. Yeah.
Okay.
So here you clamp it.
Correct.
And then maybe you put in a shunt or you do not put in a shunt, depending on various other factors. Remove that. So with newer advanced surgical techniques as well as anesthesia techniques and better monitoring of the patient, you're able to reduce the incidence of stroke significantly.
Got it.
Just like any other field with endovascular interventions, starting from late 90s to early 2000s, carotid angioplasty and stenting, carotid artery stenting, along with distal protection devices, have gained significant upstroke, and a lot of interventionalists as well as vascular surgeons.
That same, like you put a stent in the...
So you like how you put a stent in the leg. These are specially designed stents. But before you put the stent, you need to put what is called as an umbrella or a embolic protection device inside. So that when you're doing the angioplasty, through the interstices of the stent, you do not have small clots going up. Even if it goes up, it's captured. So
like the filter you have in
absolutely. And initially the incidence of angioplasty and stenting, the incidence of stroke was around 8%, but with the newer devices and better training of people, the incidence has come down. Not yet reached the level of carotid endarterectomy, the safety profile wise, but definitely here to stay. And I think is giving wonderful results.
Got it. So, but I understand as a neurosurgeon certain nuances to this because, see, you have the common carotid artery that which branches into the external internal carotid artery. So, every carotid block of 70% may not qualify for an endovascular procedure because nowadays people prefer endovascular pinhole surgery because they keep reading everywhere and things like that. So, can you just tell our viewers, when you cannot do a stenting because if it's a common carotid going into an internal carotid artery, then obviously you can't stent across the bifurcation. Is there any things
no,
like
with
that?
newer stents, you are able to overcome that. You have tapered stents where you can do a stenting starting from the ICA, coming all the way down into the common carotid artery
without obstructing the ECA.
Without obstructing the ECA can be sacrificed.
So you can sacrifice the ECA.
Yeah, because it always gets its supply from the opposite side, and it now need not necessarily be the ECA because these are all open cells. Blood will continue to flow through that. But our priority is the internal carotid artery and sealing of the plaque. So now what's happening is, if the vessel is highly calcified, extremely calcified, and then stenting does not have much of a role. But again, you need to remember, surgery also is very challenging in highly calcified lesions. So, though as a vascular surgeon, I'd like to say that, carotid artery endarterectomy is far superior compared to almost around few percentages superior compared to a carotid angioplasty stenting. But angioplasty and stenting is here to stay. And definitely there are, with the right kind of indications and with the right kind of technicians, gives wonderful results.
I agree. Thanks for that. I think you gave a very clear, explanation of all the arterial things from neck all the way down to the leg. So let's change track now. So we were actually, a couple of months ago, we were sitting in the changing room of the OT. And somewhere somebody came in frustrated, one of our colleagues came in angry because something happened. And this topic of anger management came in to this whole process. And many surgeons are extremely short-tempered, what they're outside to what they're inside. Lots of things are going on. So what is your personal take on anger or upset in the OT? Because everything doesn't happen according to plan more often than not for different reasons. So can I hear from you? I'll tell
Yeah,
before I tell you my story.
yeah, I know. So, am I angry? Yes, at times I am angry. I'm more irritable. So, I'll give you an interesting anecdote. Sudhakar Kopad, our chief anesthetist, whom you also deal with, actually made a presentation in a anesthesia conference with me and another gastroenterologist doctor in our hospital, how to deal with difficult surgeons.
Oh, really? I didn't know that.
And we were the star.
Oh, you are the guinea pigs, huh?
No, we were the stars. They said,
Okay.
they projected us, So
I didn't know this.
Yeah, this was long, long ago.
Okay.
So I have learned to manage my anger to some extent. So anger works in two ways. To keep things in check, I'd like to express my anger,
which I also do.
But I don't get angry.
I understand that. It's
Because
only
initially it used to be like that. When I get angry, my hand starts shaking, and my mood is really down or it's hyper excited, and it really bothers my surgery. It impacts my surgery.
Agreed.
So now when I have to express my displeasure, I do express it. I show my anger, but I don't get angry.
Got it. It's an interesting thing. Huh? You look angry, but you're not angry. We can't explain this. You have to experience it, do it to know what it means. Artificially angry versus really angry. Alva?
Yes. Show your anger, express your displeasure, but don't let it affect you. Not when you're doing surgery.
Absolutely.
You can come out, but anger is such a thing that, it's so impulsive. Surgeons are also impulsive. It just comes out. It's not that, you want to scream at somebody or you want to shout at somebody, but sometimes it happens. Absolutely. You feel bad at the end of it, but it's come down. I'd like to know what your thoughts about anger management, because you're always the calm, composed guy who's always smiling.
Thanks for that. Actually, when I was a kid, I was extremely short-tempered. Extremely short-tempered that you cannot imagine. So we had a group of boys. We used to play cricket. The bat was mine. The ball was mine. So I would decide how long a bat, how long a ball. Nobody can challenge me whether I got out, I didn't get out.
Basically, you're a spoiled kid.
The bat I'll take the bat and ball and come home. They can't challenge me because I was the good student, so they all used to come to me to learn during exams. So I had all this big ego. My ego was so big, Vivek, you cannot even imagine. I see my room was on the first floor, which used to overlook the gate. Our friend Albert Sharan and the Copa. I'm sorry, Kana, ego. Can you imagine? I was a school kid. Yeah, how much of ego? I can't. Sometimes when I look back and say, I can't even imagine that people tolerated me when I was like that.
Inherited or? You were the mutation?
Maybe, maybe from my mother's side, a type A personality, which I had to deal with and things like that. So then in first year MBBS, and it went on like this. And my uncles used to say, Nishtpeka kopa markotiya. Kopa bandaga, start counting in your head. All sorts of people gave all sorts of advice. And I said, what? First MBBS, I had a verbal, this one is one of my classmates in front of a lot of people. Only verbal. But the way it ended, I didn't like. I went back and realized that I said, this temper is becoming a liability for me. I need to deal with this. So far, so good. I said, okay, at least we have realized. But what to do? I had no idea what to do. There was no medicines I knew and all of those things. Then I started thinking, what? And those uncles had told me, start counting. I said, maybe for want of a better plan, I said, let me start counting. So the moment I would lose my temper, I would shut my trap and start counting in my head. 1, 2, 3, 4, 5. You won't believe it, Vivek. I counted O-N-E, T-W-O, T-H-R-E, capital letter, small letter, until I calmed down. So far, so good. But the problem was this. I would have already got angry and said something. And then I realized. So those first two words itself can be damaging, as you understand. And then that damage control recovery can be quite, impossible sometimes. So I started asking myself, how can I diagnose that I'm getting angry before any word comes out from my mouth? I kept on observing, and then I realized the earliest symptom of me getting angry is both my ears start feeling hot and I start feeling hot here before anything comes out. The moment I start feeling this, I shut my trap and start counting. It took me 2 years of consistent practice of doing this, and that's when I really got the anger under my control. 2 years of practice. Now I can confidently say that, it's very, very rare that I lose it. I can't say that I don't lose it at all, but it's extremely under control, even in situations where, it happens. So,
No, I'm not so intelligent as you. So what I did was,
what did you do?
I found a counselor
Mm.
who happened to be my friend.
Mm-hmm.
So this person, she told me that, learn to respond, don't react.
Learn to respond, not react.
Don't react. Because
Got
I
it.
always, when we have a conversation, something goes against my thought process. I, react
Correct.
and say things like you said, words, once it
You
comes out of your mouth,
you can't take it
you
back.
can't take it back.
Can't take
And it hurts the other
Oh,
person. And invariably, it's people who are with you.
Correct.
You end up
Correct.
hurting people
Exactly.
around you.
Exactly. People you love, you work with. And
So
things
she
like
told me that, please learn to respond, don't react. I've become much, much calmer than what I was. But I do get irritated at times. Whether at home, whether at home or in the hospital. But both of these things are controlled environments, because these are all the people whom I know. I never show road rage. However bad it is, I just keep nodding and keep going on. First one to put my hand up and say, no, I'm sorry if I have come very close to your vehicle, or if you've come to me, are you okay? Just go on. Don't ever get angry in the roads.
Correct. Absolutely. I agree with you. See, guys, what he's saying is, don't think that, only we are exclusive guys who have anger. Everybody has. You're seeing it happening all the time. Even yesterday they found a lawyer on Nice Road, who was found dead. Somebody called and said he was on the road and his back of the brain, his skull was open, his brain was on the road, it seems. Dead. And then they are expecting it to have been a road rage or something, some accident. Nobody knows what has happened. They're still investigating. But this is what has happened. So we really don't know what it is. So, kopa ಮಾಡ್ಕೊಳ್ಳೋದು ಮುಖ್ಯ ಅಲ್ಲ. Don't kill. There are people who kill people for being right and things like that. So anger management, I think, is very important for all of us. We covered some very interesting topics. So what are some of the common myths that people have regarding vascular surgery? You want to tell our viewers some of, just quickly, just some highlight points. Any myths are there, do's and don'ts, any of those things that you have?
It's very difficult to summarize everything. I would only say, to the general public that be aware of any changes happening in any part of the body.
Correct.
Your body tells you, whether it's the GI system or whether it's the brain, your speech, your neck pain, lower limbs. Just be aware of what's happening and always have a family physician. I mean, the whole profession of family physicians has gone for a toss now.
Correct.
Everybody wants to meet the greatest surgeon or the greatest
who's the best
neurologist, or the greatest neurosurgeon, whichever. And they don't even know that they are affected by this system. So they assume that they need to see a neurologist or a vascular surgeon. It's your family physician which needs to direct you to the
first port of call.
Yeah, and he will know better. And always have a family physician. That's what I tell my patients. And healthy lifestyle. Again, what is healthy keeps changing once in a while. Yeah, seek attention at the earliest.
Agreed.
What is from our side, my message to most of the people watching it is, almost every member, one member in a family has diabetes. It could be yourself, or it could be your patients, or it could be your friends.
Correct.
Somebody. If you see a diabetic patient or if you see a diabetic friend, please advise them to wear footwear all the time and reach out to us, a doctor, at any stage if he develops an injury.
Smallest of injuries.
Correct. Because I keep telling, the most common places where diabetic foot infections happen, one is at home, the other one is the temple. So please be very, very careful. And if you have the smallest of injuries, you don't need to see a surgeon, but reach out to your physician. Don't think that, oh, nothing will happen to me. It's a small wound. Why go to a doctor? And don't do that.
It doesn't cause too much pain also, because many of them have peripheral neuropathy and so
neuropathy, and they can't even see it. And the way our families are slowly breaking up, he won't even realize that there is something wrong with his or her leg until it starts smelling. The putrid smell comes because they have retinopathy, they're old, they can't see.
I can imagine.
And there are
children are sitting somewhere else.
Somewhere else. we have patients, they start seeking attention only after it starts smelling. By that time, it's rotten.
Correct.
That means over 2 weeks of infection has
Crazy,
happened. It starts
crazy,
becoming putrid.
crazy.
So I don't want to talk anything about vascular surgery. The only thing I would like to talk about is, prevent diabetic foot infections,
I agree.
Save
One
a limb.
message that they want you to get,
Yeah.
if they can get this one message, protect your feet, manage your blood sugar, I think there's a big contribution you're saying towards the amputation-free India.
Amputation-free.
That
like what Gandhiji says is, solutions need to be simple.
correct.
Complex problems also have simple solutions.
Correct. Especially if you caught early.
Yeah. So wear footwear, prevent a complex
Perfect.
procedure happening
So,
on you.
wearing the stocking, catching it early, wearing stockings for the venous part of it, wearing the footwear for the diabetic part of it, I think, and the lifestyle modification, I think the complex thing can really, push it, delay it, and at least have the quality of life. So before we close, I know you do this bike riding, or you used to do at a point of time. So why did that start? All this stuff riding.
No,
so what's that all about?
It's like this, Sharan. Both of us belong to the same age group.
Correct.
You have other passions.
Correct.
And I see that, how passionately you're involved in certain other things other than your profession.
Correct.
For me, sadly, it is like that, my only identity was that of a vascular surgeon.
Got it.
I didn't have any other identity. Yeah, friends here, but what do you do? And that is what gave me that kick. Okay, but then I realized that there has to be something else other than vascular surgery. Initially, it started out as a habit. Then I became addicted to my work.
To the work of vascular surgery, huh?
Okay, so it was obsessive.
Got it.
Yeah, because I did not know to do anything else. So what did I do earlier? What I used to enjoy earlier was, watching movies and reading books. So I decided, to continue with the habit of reading books, and then I started
some book reading club.
You're a part of? Book reading club. So I'm a part of a book reading club. Initially we used to do it once in 2 weeks. Now we've gone to once in 2 months, but we religiously do it. So we pick up books and we discuss about it in general.
Very good.
And then, I like arguing. I like giving a contrary view, like many of my friends, especially my dear friend Vishnu, Dr. Vishnu, who's also a vascular surgeon, who always gives a contrary view to anything you say.
Oh, I have not seen that. Yeah. Oh, I have not taken.
He is a completely contra man.
I see.
Though he believes the other way, but he likes to give his contra. So I started what is called as a debate club.
Okay, I didn't know.
So where the theme of the debate
is
club,
pro and for, for and against, correct, in school.
So I started, we called it taboo topics.
Okay.
So there are a lot of topics which are not discussed in various forums.
Okay.
I mean, it's just
give an example. Just an example. Just for our viewers. Taboo. Okay. What is taboo?
It could be about gender discrimination in surgical profession. How difficult or it is for a lady to succeed in vascular surgery or in surgical field.
Even neurosurgery.
Yeah, even neurosurgery.
Even neuro, for a long time, we used to tell women not to become neurosurgeons. Today, we have 250 lady neurosurgeons in the country.
So, these kind of things, it's very touchy.
Got it.
The various forms of discrimination. We need some forum where, we can just give out our viewpoint and take a viewpoint from the other person.
Without being judged and evaluated.
Yeah, without being judged is most important.
Correct.
Then, we called it the taboo topics. There are a lot of topics which we discuss. It could be religion, it could be caste, or it could be some war happening somewhere, or American elections, Indian. Now, our society has become very divisive.
Correct.
So, conversations are not happening between the opposing forces.
Views.
So, that's how we started the debate club.
Very interesting.
Interesting path what we found over there, that we used to give them a topic and then we used to tell them, you speak pro and you speak against it. People started getting so worked up about it, as they started
internalizing that. I can imagine that.
They started fighting with each other to such an extent, at the end of that topic, both of them would, for 2 or 3 months, they never used to talk to each other. They were
too much
hostile to each other. So it was like that. Then I changed the theme. I said that, you read this topic and come. I will tell you on that day whether you need to speak pro or con.
So don't prepare and come.
Yeah, so you must be ready to speak on either sides. And then I keep telling that, you can be angry with friends or with your relatives or with your family for a subject. But you can't be angry with each other. Both of you might be strongly disagreeing on one particular point.
Correct.
We are fighting with each other. We don't see eye to eye with regard to this point.
Correct. Not for the
It's
rest of it.
not that, we are enemies. We should not be that.
So well said.
Yeah, we should not be that. So let's just disagree over that. After that, we get back to this. Just because you win an argument about this particular point doesn't mean that, I start resenting you for that. That is what is happening now.
I agree.
Even in our profession.
So valuable point.
In our profession, somebody contradicts us regarding a second opinion, our egos.
Ego is like...
Yeah, so that is what,
Well said.
needs to come
what's
down.
coming to my mind when you're talking this is my own sister. I have an elder sister who's in US. So when after she had her daughter, and when she came with her daughter for the first time, daughter was about 2.5 years old when she came in. After that, she was born. And she threw a tantrum, as kids will throw a tantrum, whatever. Then I heard her patient is sitting her down and saying, Sanjana, I like you, but not this behavior. She clearly separated the two. Exactly what you're saying. And then so she got it that mother likes me, but not this particular behavior. It's not that mother doesn't like me. And sometimes that's what you're also communicating in your own way. I think it's very valuable, tip that you have given.
I still haven't told you how I got into bike riding.
Huh? Tell me.
So I had a friend, a patient of mine called Nityu, who had DVT very early in his age, and he had varicose veins. So we did everything for him, and he used to be a avid bike rider. So he was in his late 20s, and I had touched 40s. So as usual, we all grew up watching Hindi films or Kannada films, where, either the villain or the police rides a bullet motorbike.
Correct.
So that is when I thought, if you have a bullet
But did you have a bike when you were in college?
that is, the usual
Yamaha,
100cc bikes and all that stuff. So I bought a bike and then
Which was your first bike?
My first bike was a Bullet Thunderbird 500cc. So then I started going around and, I used to enjoy my weekend rides.
I know, I remember that. You used to tell me that. You had all the full gear up. I remember that.
So, all the band baja and all this stuff. Yeah. And then it's so
How big was this gang of yours?
I had 3 or 4 separate gangs.
Oh, adu bere.
Yeah.
Oh.
So go out with different set of people. I used to go with different gangs and just hang out. So we had almost around 40 to 42 bike colleagues from 3 or 4 different gangs. It was nice. But what started happening was, these are guys who leave on a Friday and come back on a Sunday evening.
Oh, that long?
Yes.
Or there are all these IT guys who don't work on the weekend. We don't have the luxury.
So we don't have the luxury of
5 day
that. And then slowly I started saying that, guys, you know what? When you're coming back, I'll come and join you near Ramnagar or I'll join you near Mysore. So we'll come back together.
Got it.
So you just want the company. So slowly it started coming down. And then when I was 45 and 1, then I was just sitting in the hospital thinking about bike ride and all this stuff. Then, there was a neurosurgeon called Dr. Asha Bakshi.
I remember her. Yes.
Yeah. She said, she said, what are you planning? I was making a route map. I said, I'm going on a bike ride and making. She just looked at me and said, midlife crisis.
Why did you say that?
I don't know why she said that, but then I realized I said, maybe. So that's how it was.
Typical Asha, this is.
Yeah, so maybe it was midlife crisis. I still enjoy my bike ride, but
you have a bike.
I still have my bike, and a lot of my friends have really fancy, expensive bikes. And
Harley Davidson and all those things. Huh?
Yeah, Harley is, I think, is a wonderful bike, but I still prefer a Triumph or a Ducati.
Okay.
And my only problem is after 150 kilometers, my bum hurts. So
Captain Soras will become.
Yeah, so then I finally realized I've touched Maku. That's a word which says middle age catching up.
MAC, immediate catching up.
MACU. So when patients come to me and says that, I've got pain here, pain there.
Oh, Vishnu was saying that I have pain here. I remember
So
that.
finally I tell them either you have vitamin D deficiency or it's MACU for you. Then they want to know what MACU is.
MACU. Interesting. I learned a new acronym today. So one more thing we didn't talk about, I want to talk for sure, is your passion for the stock market. So I need you to, I think you have a fantastic story there. Why don't you tell us about
No, it's like this, I think all doctors or all students cutting across all spectrum, right from the student days, need to be made aware about finances.
I agree.
Because
Ask me about
the way our parents brought us up was, first you study.
Money is not important.
Money is not important.
Correct.
First you study. Okay. And in our case, you study for around 12 years.
Wow.
So all of us get into a profession, one or maybe out of the passion. Second one, you need to make a living to support your family.
Correct.
And finally, for you to become good in your profession, it took you around 7 years or 10 years or 15 years.
Yes.
And then you get money in your hand and you don't know how to do it. That is when, your dad's friend who's a LIC agent or somebody else who says post office monthly income scheme. And, you have this various retired people, who want to.
Correct.
So that is how you end up having 8 or 10 policies.
Correct.
That's what my dad did. 10 policies and various other products, which you have no idea what to do with.
Correct. And no idea what it does also.
So, right from a very, very early stage, when I was 17, I realized that, I need to learn a little bit of finances.
Really? At 17, what triggered you?
Nothing triggered me. I just wanted to learn.
Very
and then finally, when I decided to get into medicine, I wanted to be.
At that age, nowadays 17, anybody can take a share, share can this one, but that
time
was quite a challenge.
Were different.
So very, very challenging.
So it used to be like this, so I decided, if I want to do MBBS, it has to be in Bangalore. I don't want to be anywhere else because Bangalore Stock Exchange was where Unity Building was.
Correct.
Behind Ravindra Kalakshetra.
It's in this one, no?
Yeah.
Of
now Bangalore Stock Exchange is gone.
Gone.
Now you can do it on your laptop.
Correct.
So, had a government seat, was offered KMC Hubli, but then finally got it down to KIMS Bangalore because it's closest to the stock exchange. And
he is selecting a college because close to the stock exchange. I mean, you're the first guy I've heard who was bashing it like that.
Those days, you could literally go in the afternoon at around 1:30.
Really?
You could go over there, and there was a strange way of making money in those days. It's like this, Hindustan Lever share those days was around 70 rupees for a 10 rupee share. And you had to take physical delivery of the shares and then send it to the company. So you had, the minimum trading lot was around 50. You had some people who had 5 shares, 8 shares, they can't sell it freely. And when they sell it, it has to go at a discount. So I used to collect all these discounted shares, 5 shares, 8 shares, 10 shares, 15 shares. Collect it, make it 50 shares and then send it to the company to transfer it. So you already have around 20% discount and you made 20% money.
Fantastic.
And then when that goes up,
smart guy.
So that is why, I started telling my children right from their 8th standard, I start teaching them what is net
financial literacy.
Yeah, I think it's very, very important.
I agree.
Because by the time we get a hang of it, it's little too late for us.
Because money over time makes the magic.
Yeah, absolutely. So I make it a point even to all my students or whoever I meet.
Fantastic.
Whether it is the maid who works in my place or the gardener, always tell them, how do you save money effectively? Everybody works hard for the money.
Correct.
And, we want to use it for the betterment of our family or our children or our loved ones.
Correct.
And use it wisely. And if you can't educate yourself, we make diagnosis of, patient walks into the hospital and when you're an intern, you can look at the patient, you examine the patient, at least whether it's the GI system or whether it is the urinary system, locomotor system, neurology case and respiratory. If you can make all these things, why can't you analyze a simple stock? You can, provided you put a little bit of effort.
Correct.
Now there are enough tools to help you. I'm not saying punt on it. I'm not saying you to do anything with futures and options. I would say invest well. It's good for your family and
Correct.
for your own security,
So-
because we are in a very, very insecure field.
Agreed. And I think the bottom line you're saying is financial literacy. Understand, even if you give it to somebody, why are you giving it to him? What is he doing with that money? What is going to come back? Because he may invest it in where he makes money, and he is having a jolly good time on your money. And we know that has happened more often than not if you're not careful about what is
But
going on.
nowadays, the guys who take care of your finances, they're also professionals now.
Correct. Agree.
Okay,
Agree.
those days of swindlers
Correct,
are
has
over.
gone.
I personally feel that there are a lot of good
Agreed.
youngsters
Which I agree.
and
Which I agree.
people are there.
Which I agree.
They are there to help you.
True.
Yeah.
But you have to find the right-
Occasionally, a few bad apple in any profession,
Correct.
there might
Agreed.
be there,
Agreed.
but invariably all of them
True.
mean well for you, because they do a good job. If we do a good job, just like how we get patient referral from
Correct.
other patients.
Correct.
So basically,
They love.
sincerity, hard work, and availability, I think is
Agreed.
the key for
Agreed.
success, and plus being honest,
Correct.
ethical.
Integrity is that thing. Very
Absolutely
good.
essential. And then I think any profession you will get well.
I agree. So just to add, how I educated myself in financial literacy was, I'm a big follower of Robert Kiyosaki, the Rich Dad
Rich
Poor
Dad,
guy.
Poor Dad, yeah.
You remember in that book he talks about the cash flow game. So at that time I imported the game from the US. I bought 2 boards and 6 people. It's like a Monopoly game, but much more sophisticated than that. I know whether you played that game.
I have.
So I played the game about 500 times. So I would call people, because you learn from everybody, not just yourself. You know how he makes a decision. Because after some time you see people are thinking it's real, they're crying, they're laughing, all of those things. And then I would have, like how you had the book reading session, I would have cash flow sessions. And we'd run 3 shifts. Because I was loving the learning that I was having from different people. Then start getting my kids to start learning, because you also learn to write a P&L and all those things. Very valuable for me to know what's in. Now, a lot of those principles I still use today in other books and all of that. So that's what it is.
I used to gift most of my friends who were not financially literate,
His book, huh?
including my children. So I used to literally buy Rich Dad, Poor Dad in 10s and 20s.
Whoa,
And
I've
I used
not
to gift
done
it to my
I've done the game.
students. And I used to gift it to a lot of people.
Fantastic.
Because it's a fantastic reading.
I agree with you.
It doesn't need
I'm glad that we have so many things in common. So Robert
I think
Kiyosaki, Rich Dad Poor Dad is, I think, a great starting point. It really opened up my brain completely to know what, and he's so simple actually. If you look at it, he keeps it so fundamental.
All complex things are simple. Okay, it's we specialists who make things complicated.
Correct.
And then try to solve it simply.
Correct. I agree.
So
I think we had a great chat, Vivek. I think thank you very much for all your wisdom that you have shared. It's invaluable what it is. And I think like all things have to come to an end. I think I'm going to call an end to this whole process. So on behalf of the Rebooting the Brain team, I thank you very much for all that you have done, continue to do. And I wish you all the best for expanding vascular surgery. And also, as the current president of the VSI, I hope that, you can really make a difference in, getting the message across to people. We are with you. We'll play a role in the whole process. As a last part of what we do, a book gift to all our. So this is a Rebooting the Brain book that we have written. So please accept this as a token of appreciation for our side.
Thank you, guys.
And that's all it is. So thank you very much again. Appreciate all the wisdom that you give.
Sharan, it was wonderful interacting with you. I never realized that, so much of time has passed. And I was a bit nervous as to how this would go. And the way you've taken the conversation and kept us all occupied. I think kudos to you and your team.
Thank you. Thank you.
All the people sitting out over there with a smile. Okay, after listening to us talk for around 2.5 hours. Fantastic job, you guys. Thank you. And thanks, Sharan.
My pleasure, Vivek. And viewers, before we wind up, don't forget the housekeeping rules. Subscribe to our YouTube channel. Hit the like button. Share vividly, because you don't know who is the next diabetic foot we can avoid an amputation, or somebody with a carotid problem that he can avoid a stroke. Guys, you cannot imagine, these are life-saving information that you want to have. Hit the bell icon And obviously, be generous in your comments after you see it, because we want to hear from you what you have understood, what you have learned from that, and also if you want any more information from us, like this kind of information, please reach out to us. That's all from me. Thank you very much. Jai Hind.
Kind of been a guinea pig for any new drug comes, they try it on me.
Status migrainosis. She's had status migrainosis. Not once, not twice. You cannot even imagine. So why don't you share to our global viewers what...
I mean, when you say chronic, this is chronic. For years together. And yes, different kind of medication, different intervention. It would come under control for some time, and then some trigger takes off, and then it's back again. And then it would last for a week, and that definitely affected my ADLs, my work, everything. It would affect. It would just put me off. So every time there was, one episode is over, I've gone on, the prevention mode and everything. Somewhere, things are settling down. One more trigger happens, gone. So that time, all the conversations happen between the neurologists and the neurosurgeons and pain therapists, and everybody together, they'll come up with a new, some new drug in the market, new thing. This is better than that, new strategy. So I'm there to try it on. So for me, one side, I'm a doctor treating the patients who have pain. I've had enough experience treating his patients who he has referred, or pain physicians have referred, to give them relief. But on the other hand, being the patient, I really understand when somebody says it is unbearable. I really understand. And when you say chronic, I understand what chronic is all about. It has been...
I've seen, she's lying in the room inside the hospital, and somebody is pulling a trolley somewhere outside. It's just, stop it. It's so far away. You cannot even imagine how much you used to get irritated just by the sound that was going on. Put off all the lights.
And it's typical, when you read in the textbook, you kind of read the symptoms, right? Photophobia, phonophobia. I mean, these were terms when I read it in the books. But then when I actually experienced the photophobia, I would ask them to put iPad on my eyes, or cover bedsheet on my eyes. Oh, it was that bad. And like I said, little noise, they would put cotton in my ear. I could still hear something, and that would irritate me. It was...
What made you wanted to be a doctor from your childhood, or See, I want to be a neurosurgeon from 8th standard. That's what I kept telling everybody. Did you have any such stuff happening in a childhood or something like that got you to become a doctor?
Yeah, I'm the first physician in my family, and when we were young, first few years, we want to be engineer because my cousin was an engineer and things like that. And back then you were either an engineer or a doctor.
Correct.
Then I think I had, looking back at it, I think I had post-viral asthmatic type attacks. So for a year or two, I had a couple of, used to get a little bit of wheezing, respiratory, for whatever reason. And we used to go to our local pediatrician. I remember his name, Dr. Jaiprakash, really nice guy. He would make you feel so comfortable. You walk in, and I didn't know what he did. I didn't know. He looked at my eyes, my tongue, he listened to my lungs, and he would give me a shot and give you some pills, and you go home, and in a couple of days you start feeling better. And even before the medications worked, even before the injections worked, I felt so much good that I went to talk to him. I'm going to feel better now. I almost...
Psychology.
Yeah, it was amazing. Then he kept like, like he was... I said, maybe I want to be a doctor. So from that time onwards, every time I met him and he was close to our house, sometimes we would run into each other. So, Henry, doctor, he was like, hey, hi, doctor, how are you? Like, that was like amazing. I'm like, wow, he thinks I could be a doctor,
And the other extreme is there are people who don't get MRI done. They keep on treating sciatica. That's the other extreme. I still remember one story of a orthopedic surgeon's brother. Okay, he had this classical L5. He kept sciatica. He kept on treating. And 5-8 years, Something like that. And finally, everybody got frustrated. I said, let us one scan, Mabra, out of sheer frustration. And he had an L5 root schwannoma. He had a tumor sitting on that L5 root.
Wow.
So what I'm trying to make you understand is not doing the scan is a problem. Doing the scan has limitations. Eventually, all I'm trying to say is a right clinician who understands back pain, neck pain, makes the right decision is the key to make sure that the minimum effort is put to the maximum benefit you have for the longest period of time.